Sir, we are live now. Good to go.
Namaste to everyone. The ability of living organisms to adapt to change their state in response to any stimuli is called biological plasticity. Not being static and being plastic to the change lies at the core of our own evolution and development. We have adapted ourselves according to our surrounding. Like other animals, we were also hunting for the food and survival in our initial times. And we were also quadrupeds, moving and running on four legs. But adapting to the situation, we gradually transformed ourselves to bipedal by sparing two hands for optimized other working. Likewise, so many other changes have made a successful survival possible for us. And now, such changes have become so routine for all of us that we cannot even imagine about the existence of our older ways. Can we think that we were also moving across this planet on four limbs like animals? Certainly not. And this is what embracing and accepting the change that becomes new normal, which over the time turns into routine or normal. So, our very nature of adaptability to the change is probably the secret of our existence. And certainly, it has made us most intelligent inhabitant of the earth. Likewise, so many such events have changed our behavior over the time, which has shaped the history of humankind, and in fact, it has made us what we all are today. Again, we are in the middle of a watershed moment for our kind. Dreadful COVID-19 pandemic, which is creating a huge pressure on our social fabric. It has compelled us to behave differently. Like SMS nowadays are defined as sanitization, mask, and social distancing, and not the short message services. In reality, we don't have any choice to change our behavior, and respecting a COVID time has now become a requisite for all of us. But who is playing a role of an advocate for this change in terms of inculcating new and health conscious behavior? Yes, again, the responsibility lies on the already loaded, but of course, the strong shoulders of you all healthcare custodians. Alongside of being the evangelist for the change, the healthcare professional and healthcare sector itself are also getting change and adapting a digital transformation like telemedicine, teleconsultation, telediagnosis, telepharmacy, and many more. These all things are not new and they have not come out of the blue. They were looming around for a while and waiting for their time to come. Here, this pandemic has played a role of an accelerator, and all such digitalized approaches have come to the fore and started taking a central place in the scheme of things. And perhaps it is going to become the new normal for all of us in the coming time. So the digitalization is no more a future, it is the present standing in front of us. In such scenario, how can the updating knowledge behavior left to be transformed, which is actually a genotype of the clinician, and this approach is also phenotypically getting digitalized to respect to the social distancing. Yes, having the virtual CMEs and conferences to update the knowledge is a need of an art and not merely a good thing to show. But as we all know, there is a problem of plenty. So many knowledge update platforms are there, and it is very difficult to identify the right platform which gives right information to the right set of the experts. That is where our present platform, CrossConnect, actually stands out in serving the Indian clinical fraternity successfully for the last 5 consecutive years. And yes, we can take a lot of pride for the CrossConnect that provides comprehensive knowledge update through the best set of the experts. Abiding to the requirement, we have also evolved and adapted in our approach by transforming into the virtual conclave. We have already done previous 3 virtual CrossConnect for the present year. With the seeking the blessing from the Almighty and under His auspicious presence, we are happy to reveal the 4th and the last edition of the CrossConnect for the year 2020. On this new normal note, I, Dr. Hiren Prajapati, from the CrossConnect team, would like to welcome you all delegates as well as the faculties for today's scientific conclave. Today, we are fortunate to have Dr. Uday Jadhav and Dr. Subhankar Chaudhary with us as course directors and craftsmen for upcoming scientific fiesta. As a customary, I would like to read their CVs in brief for you. Dr. Uday Jadhav is a consultant in cardiology and cardiac CT department, MGM, New Bombay Hospital. He is an honorable professor and faculty, MGM University of Health Sciences. He has done multiple fellowships from different scientifically accredited bodies or organizations. He was program director for ASH scientific meeting in India in year 2013 to 2018. He was program coordinator for the ACC India Rhythm meetings for the year 2014 to 2019. He has done his research work in the field of dyslipidemia, subclinical atherosclerosis, hypertension, cardiac CT, and CT radiation. He was a part of a principal investigator in a study like RAS India study, strong study, the efficient study, and also the investigator of the protection seek study. He has recently written a chapter on morning surge of blood pressure in the ESH textbook on hypertension. Welcome, Dr. Uday Jadhav. Let me introduce our another course director, Dr. Professor Subhankar Chaudhary. Currently, Dr. Chaudhary is a professor and head Department of Endocrinology, IGPGMR and SSKM Hospital, Kolkata. He is the editor-in-chief, Indian Journal of Endocrinology and Metabolism. He was president of Endocrine Society of India and currently is a president of Endocrine Society of Bengal. He is a member of Subject Expert Committee, CDSCO, Government of India. He is a founder patron of South Asian Federation of Endocrine Societies. He is also a member of Research Committee, RSDI. Dr. Chaudhary's the area of interest is in gut microbiome and gestational diabetes and pathogenesis of Graves' ophthalmopathy. Dr. Chaudhary has published around 188 papers in peer-reviewed journals. Welcome to Dr. Subhankar Chaudhary. For taking the scientific event forward, I would like to hand over this virtual podium to Dr. Chaudhary for his opening oration. Over to you, Dr. Chaudhary.
A very good evening, all of you. Let me share my screen. Right. Some in the audience may be a little bit surprised at the topic of my oration. However, I feel this fits very much into the concept of CrossConnect. We are connecting here not only across separate disciplines of medicine, but going even beyond and mingling with arts. So what I would intend to do in the next 20 minutes or so is to take a ringside seat and of course, take all of you along with me and look at events as they pass by in a roughly chronological manner and let these speak for themselves as to whether we need to have a conflict or concord as regards science versus arts. If we look back, when did science start? It may arguably be said it started with humans' discovery or control of fire, which was 400,000 to 700,000 years before Christ. Some would claim that it happened even earlier. And if you take the earliest stone tool making as being endeavors of science, then that happened even earlier, more than 2 million years ago. So science is old. What about art? Would anyone conjecture where was prehistoric art recognized for the first time on this earth? When? It was at Bhimbetka, the rock shelters. And where is Bhimbetka? That's 45 kilometers from Bhopal. So you can be proud that the earliest forms of art on earth was found in India. And these cupules, these are hemispherical petroglyphs, stone art. Don't look much, but believe in me, that was the birth of art, at least visual art as we know. And that also started about the same time, but maybe a little bit later, again, anything between 290,000 to 700,000 years back. So maybe if we see a look at the birth, maybe science had a birth somewhat earlier than art. If we look at the etymological origin of these words, science means knowledge, having knowledge, whereas arts, derived from Latin ars, means skill as a result of learning or practice. So from this sense, to me at least appears that you have the knowledge first, and then possibly you develop the skill. So that way maybe arts comes after science. But if you look at the wisdom of Pythagoras, of course, as children, we may have been bothered with Pythagoras' theorems and theorem and the different sums attached to it. But he made an immortal sort of statement where he saw an intermingling of science and arts. So what he said was, there is geometry in the humming of the strings, supposedly of the harp. And he found music in the spacing of the spheres. Here the spheres refer to the spacing of the spheres refer to the proportionality of the movement of the different celestial bodies. So there was no difference possibly between science and arts in the time of Pythagoras. However, if you come down maybe another 200 years to the time of Aristotle, maybe when people had much more to learn, Aristotle felt that there should be a compartmentalization between episteme or knowledge and techne or craft. So possibly if we try to look at when it started, possibly it started with Aristotle, the division between science and arts. If we think of medicine, and this is of course coming down almost 2000 years after Aristotle, when it was recognized that medicine is not only a science, but also an art. And in today's time, in 2020, I feel we physicians should not be ashamed to accept that this statement holds true even today. And in fact, what separates a great physician from a good physician is possibly the art of practice of medicine, while the science, underlying science, remains the same. And then we come down to the Romantic era, which started as a beautiful movement, literary, musical, visual arts, intellectual, in late 18th century in Europe. And one of the finest exponents, the poet Samuel Coleridge, found great delight and beauty in the neatness of Newton's scientific experiments. So in the Romantic era, you have appreciation of the scientist by an artist, of course, here a literary artist. And then we come to someone who is less well known, possibly, James Naismith. He lived in the 19th century, but he dreamt of the 18th century Industrial Revolution. And he dreamt of the different gadgets, instruments, machines, and he sketched them out. And then, as an engineer, he was an engineer by training. He went out to make those big machines, and what we have here on display is a steam hammer, a huge, giant steam hammer. However, he grew up in the fold of his father, who founded the Scottish School of Landscape Painting. And so after he had made that machine, he would quickly sit down and sort of honor his dream by making an oil painting out of it. So clearly, the scientist, the engineer, and the artist could well move from one position to the other in the same human being. Today, we boast, we have learned a lot. We know about anatomy, physiology. We feel that the functioning of the brain is much better understood, which it is. And we tend to associate the left side of the brain in a typical right-handed person being associated more with logic, with rationality, with analytical properties. Whereas the right side is more intuitive, more subjective, but looking at whole. We understand by science, by medicine, better what underlies emotion. We understand a little bit about the limbic system, its components, thalamus, hypothalamus, amygdala, hippocampus, and so on. But science cannot fulfill those needs. Neither can science explain the myriad emotions felt by looking at the same picture or photograph, for example, here of the Mona Lisa. So those are the limits of science that we need to remember. Again, as scientific individuals, when we are confronted with a problem, we always try to solve it by conducting an experiment. So here we have an experiment where 116 undergraduate students, equally divided between science and arts, were put to a number of tests that involved convergent thinking, divergent thinking, and problem-solving skills. What would you expect the results were? Well, whatever may be your expectations. The results were there were no differences in problem-solving skills between arts and science students. So it's no wonder that Albert Einstein and the great Spanish surrealist painter Salvador Dali can well exist in the same room here, of course, in a wax museum. And then we can take a lesson from this unmistakable Albert Einstein, the great statement that he made: the intuitive mind is a sacred gift, and the rational mind, which drives science, is a faithful servant. We have created a society that honors the servant and has forgotten the gift. Let's hope, if this has happened, we can make the necessary course correction in times to come. Now, we should quickly look at what is there. Does science bat for art? And on the other hand, does art do something for science as well? Well, science could, of course, be the subject matter, could be inspiration for art, it could be a medium for enhancement. We can have several examples, but we'll take one. And that is this beautiful picture, the poppy field near Argenteuil, by the great impressionist Claude Monet. You can see this still in the Metropolitan Museum of Art in New York. Now, what is remarkable is the dynamism in this picture. You can almost feel the poppies are waving in the breeze. Monet is supposed to have used the principle of equiluminance, which means the colors are equally luminous between the poppies and the grasses. The difference is not made out in being less dark or more dark, but in different colors. And you can appreciate this if you take away the colors, as in a gray tone photograph, and you see this dynamism is gone. Many of the flowers are also gone. And that is because so intelligently Monet used the principle of equiluminescence, luminance, which is of course a scientific principle. And then what about art for science? Well, it can give a form to the unseen. Of course, art underlies the making of all the scientific fiction, films, and literature. It can bring back the past to the present, as in your Jurassic Park and so on. We'll just have one example. What is a supernova explosion? No one of us has seen a supernova explosion. It hasn't happened in recent times. Probably the last one happened in 1600 something. But we have an idea of what it is because of artists' impression. This is, of course, the eventual happening, sort of evolutionary development of a big, huge star as it explodes. So here, art is helping our understanding of science by providing a form. And then this, we see in architecture, not in every architecture, but at least here in the architecture of Anton Gaudi. You see that sprinkled all across Barcelona. You see science meeting art. You see the Sagrada, you see the Casa Bayo, you see the Casa Mila, you see the Parc Güell, the beautiful blending of science and art. So it's not that it's science versus art. It could be science and art all together. And then the commonality also persists through the individuals behind these scenes. We know of the intense passion of Vincent van Gogh. When he used to start a painting, he would sit at the easel hours together, even days together, without having any food or water or anything. And we have on the scientific field someone like Marie Curie, who was so dedicated in her work in the lab. He spent months there and was exposed to radioactivity again and again. And eventually she died of aplastic anemia because of her passion for her work. So again, it's not this versus that. It is common at many a time. Again, if you look at the iconoclasts who have spoken against established wisdom or the norm, they have been treated equally by society. On the left, we have a caricature on Charles Darwin in a newspaper in 1871 after he brought out his Origin of Species, lampooning not only his theory, but also him personally, as if he was the only person, only human being who has evolved from the shape of an ape to humankind. And we all know Salman Rushdie being at the ire of large number of people and being under death threat after he brought out the satanic verses. So again, there is similarity between those who pursue science and those who pursue arts. Here, of course, it's literary arts. We often say art is for art's sake. What about science? Science is supposed to work for fixing practical problems, give you immediate results. But if I ask you, names of three great scientists that you can think of. Probably the ones that will talk of is Newton, Einstein, and Darwin. Now, what did they discover? Did they come up with a CT scan? Did they come up with a treatment for malaria? No. They wanted to understand the world for its own sake, driven by a sense of wonder. So it's also, to an extent, science for science's sake, not for fixing practical problems. Again, we see we are not talking at cross purposes. However, we also know that whatever or what is allowed to flourish, what is being promoted, is determined to a significant extent by commerce. And here comes Karl Marx's theory of economic determinism, and also these days by politics. So it's not always that you can allow either science or arts to grow on its own steam. They have different other factors to shape. Because you do not have many Winston Churchills these days. When he was asked to cut arts funding in favor of the war effort, he simply replied, then what are we fighting for? And that brings us to the last of my slide this evening. If we think of the pinnacle of scientific glory, I think one of the greats has been man being able to fly out of the earth and step on the moon. Not too many long back, on the 20th of July it was, in 1969, that man stepped on moon. That was a huge event. But that didn't stop science's pursuit for further growth, for quest for further exploration. And amongst others, the Voyager mission started. Both Voyager 1 and 2 were launched in 1977, 43 years back. Their aim was primarily to have a better look at Jupiter and Saturn. Wonder, wonder. These Voyagers outlived their expected longevity of 5 years, and they went on, took us to the outside of the solar system. We had a look at Neptune, Uranus, and then, wonder of wonders, one day, August 2012, Voyager 1, and November 2018, Voyager 2, they hurtled across, they crossed the restricts, the Maya of our solar system, and went into interstellar space, where they're still moving, hurtling at speeds of 35,000 miles per hour. While they are sending back very important scientific information, they're continuing to do so. Is that all? Well, on both of these Voyagers, there is a 12-inch golden phonograph record, which has captured the sounds of Earth. These have been very carefully curated by a committee which was chaired by Carl Sagan. And now, if I would request all of you to close your eyes, sit back, and imagine you are an alien or a far future human who has come across this Voyager. You can still appreciate the music, the timeless music. So you have Kesharbai Karkar singing to you in outer space, and that's music and science having their holy marriage in interstellar space. Thank you, ladies and gentlemen, for being with me on this journey, and I hope this helps us have or develop a more holistic view of the things around us and helps us get over petty quibbles. Thank you very much. Have a very good evening.
Thank you, Dr. Subhankar sir, for giving this wonderful and admirable oration. And I would like to invite Dr. Uday Jadhav sir for his oration. Yes, Dr. Jadhav sir, you are muted. Please unmute.
Thank you, Dr. Subhankar. It was a pleasure to listen to you. I wish you could have gone on for a while. This was just amazing, the perspectives which you put up, and takes us long back in history and other things that we try and learn. Okay, so dear colleagues and friends, I'm going to speak on CT coronary angiography. The reason is not to tell you about the intricacies of the art, but how you can utilize it in clinical practice. So let me straight away share the screen and start my presentation. Oh, sorry. Can I go back? I'm sorry, I went to the final slide, so let me come back on what's interesting. All right, thank you very much. So what is it that clinicians and physicians need to know in cardiac CT? How we can implement in clinical practice?
Sir, please double click. It is not showing the screen here. Double click to enter the full screen mode.
Is it better now, Hiren?
No, sir, it's still not visible. Otherwise, sir, you can again share the slide. Stop sharing and
Maybe,
again share the slide.
No, there'll be one share button on the top. So please click on that. Share screen button will be there.
Yes, let me see if we are doing the proper things here. Is it now visible?
Now, sir, now, sir, go to the full screen mode. Now it's fine. Now it's visible. Yeah.
Thank you very much. I will save the time, please, as I wasted a minute or so. So what I'll try and explain today is how clinicians can use cardiac CT in practice. And we are aware there are two primary indications, right? We can use it in patients with stable angina. These days, we can also use it in patient of acute chest pain. In the era of COVID, this has started becoming very common and popular that we have been utilizing this art. And so let me explain you a few things. What is the first utility that clinicians should do of a cardiac CT? It is the ultimate screening tool for determination of atherosclerotic coronary artery disease. So if you look at this picture, what does it say? You take a CT scan of the heart, just a basic CT scan. It takes 3 minutes. There isn't any radiation involved. There is no intravenous contrast. Really speaking, it doesn't require a breath hold. Those white particles, shadows that you see on the LED territory are calcium hydroxyapatite crystals. That means this represents plaques, atherosclerotic plaques, which are organized. When you get this, you already know there is a coronary artery disease. This is the proof of coronary artery disease. And as I'll discuss further, what it indicates is there is a plaque. How soft the plaques are, how vulnerable the plaques are, is a different story. So this basic test without any intravenous injection and cost practically very, very small amount helps us tremendously. What is the utility? Here is the left anterior descending artery on a cardiac CT. When you see those white spots of calcium crystals, so as to say, these atherosclerotic plaques will also tell you that there are softer lesions associated elsewhere. For example, here, and there is a smaller left main artery, and there is a soft plaque here. So the presence of these plaques also tells you there are plaques which underlying could be softer. One of the best paper you can go through on calcium score is by Michael Crawford. What does it tell us? If the patient has got a coronary calcium on CT coronary score, the chances that he will get a major adverse coronary artery events over 2 years is as high as 84%. There may be 16% who may exhibit non-calcified plaques also, which we will discuss. So the presence of coronary artery calcium tells you the plaques and predicts events. The great news is the other way around. The absence of coronary artery calcium on a calcium scoring tells you that this person is free of coronary artery disease, almost a warranty for 5 to 10 years, with some exceptions which we can talk about. Now, how do we clinically pick up a CT coronary calcium score and a treadmill exercise test in practice? Stress tests will tell you what are the functional consequences of atherosclerosis, but it cannot detect atherosclerosis by itself, right? Myocardial ischemia and ST segment changes can be caused by conditions like microvascular disease, like left ventricular hypertrophy, not necessarily epicardial disease. So stress testing cannot detect non-flow limiting plaques. When the calcium scores are more than 400, they are a much better indicator of coronary artery disease, and therefore you can start using the calcium score for our advantage. Let us come to some of the myths that it has a high radiation dose. I have been working on some of the very important papers on radiation. If you look at the radiation which is given by coronary calcium by CT coronary angiography, it's about 1.227 with an average about 3.4. So the protection 6, and I was a part of the German study, international, this is the best publication in a real world practice. It was 3.4 millisieverts. If you do a coronary angiogram, it is almost more than 2.5 at all points of time. That means in a well-done CT in today's date with adequate slices, you can lower it down to 1.2, but in real world, you are still at 3.4. That's not bad. I see clinicians asking about this. Well, we do CT coronary angiography, there is a lot of radiation involved. Then when you do abdominal CT with contrast, you still are giving 4.1 millisieverts, that's higher. We almost never question ourselves or our patients when we send them for CT abdomen, right? We never say, we just say, okay, go ahead, do the plane and contrast. But the radiation is much higher typically than what you will get with a CT coronary angiogram. So radiation is a risk, as always in all CTs, but the myth that is very highly radiating is not true anymore. Second, patients may not be able to hold the breath. That's very true. When we do 64 slices, we still need about maybe 15-second, 12-second breath holds. Now that you have higher slices, 128, 256, and this is a very recent graph I showed for 256 to explain you a simple thing, A and B. What does A tell you? When we start a cardiac CT, you inject the contrast, the scan starts, right? And when the scan starts, the breath hold starts. BH is the breath hold time. So the breath hold starts right from here. The contrast has been injected. When the contrast appears in the descending aorta, the scan is triggered and you get a coronary image. That happens somewhere here. So the patient effectively holds his breath from here to here. With the new scanners and with the new techniques, what you can do is you inject the contrast, patient can continue to breathe, take his breath in and out. When it reaches the trigger point, that's the time you give the patient a breath hold. So the breath hold then becomes very short. We are able to reduce it to close to a count of 8. With the higher scanners, you don't need, it's a single breath, so you don't need any more breaths. Okay. So radiation breath hold. Third is the contrast. So what about contrast nephropathy? That's the classical definition of all CINs. It's a 25% increase in the create from baseline or a 0.5% increase in the creatinine value within 48 hours. Typically, it occurs within 2 to 3 days. It peaks at around 5 days, resolves in 14 days. If you look at entire CT, it occurs in 2% of patients, right? In real life and in our experience, it's not very commonly noted. Now, does that mean that I'm advocating that contrast is safe and you don't get a nephropathy? We may be missing a lot of patients. And why is that? One of the reasons is you never normally try and get their creatinine done on outpatient basis at third day or fourth day or fifth day. This is where we'll have to be careful. That means rehydration, post-hydration is very important. And gone are the days of keeping patients NBM for 12 hours. I do not do it at all. Patients are allowed to take their breakfast, and I prefer to do that so they are overnight well hydrated. Give them a 3 hours of empty stomach meal by mouth, and then you can go ahead and do it. Scott Hart is one of the finest studies. It tried to look at coronary CT angiogram for 5 years risk of myocardial infarction. These were patients who were either underwent a treadmill test or a coronary CT. They had a low risk, they had a chest pain. So these are the patients you see in clinical practice. Large number of patients, including women. 2 years follow-up in the mean. Patients were about 57 years old as we do in clinical practice. Exercise EKG, the ECG, that's the treadmill, was performed in all subjects. They are only abnormal in 15%. 62% of this patient who underwent a stress echo, because that's what the next step you say, let's send them for stress echo. At a normal reason, 16% were inconclusive. Here also, Scott Hart had a radiation dose not exceeding 4. Here is the primary endpoint. So when you look at standard care, only treadmill and giving medicines, do a CT coronary angiography and do the medicines, you can see the relative risk reduction. Absolutely wonderful. Straight away, you get a reduction of 40% in non-fatal MI and 40% here, right? That means CT increase the certainty in the diagnosis of angina due to coronary artery disease. And in this patient, you get a significant reduction in rate of death from coronary artery disease or myocardial infarction at 5 years than standard care, without that these patients require a higher incidence of coronary angiogram or coronary revascularization. So should CTCA be the non-invasive test of choice? Unequivocally, yes. Other available tests, you do any test for that matter, you can talk about the risk, right? But it does not make a difference to the patient. Patient only has one question. Do I have plaques in my coronary arteries? Are my coronary arteries diseased or not diseased? The only way to be sure about it is to do a calcium score. If it's 0, rest assured. If it's showing something, go ahead, do a cardiac CT, but not in, of course, acute MIs you don't do. Is it as good as a conventional luminogram? Here are the pictures, you can pick it up very clearly. 1, 2, this is a right coronary pathology. This is more of cosmetic value, but I do go back to the cosmetic values also just to get an excellent correlation. Significant right coronary disease image, as you can see. And here in the right-sided image, you see a plaque with a thrombus, and I will talk about it in a while. Right? Completely occluded artery. There goes the arrow. So you can see the lumen showing the dye contrast flowing through, and then you see a plaque, which in my opinion is extremely bad. If you see the right one, and I will remind you of this, the right screen image, the upper one followed by occlusion. The right one, if you do a coronary angiogram, this will be labeled as maybe 50-60% lesion, but this is horrible. This is one of the indicators of vulnerable plaque. Sensitivity and specificity, even if you don't want to go through all this, close to 94 to 96%. Now, one thing which I want to stress upon to the clinicians, we are stenocentric. That means we always say, look, CT reported a 40% lesion, coronary angiogram reported a 50% lesion, or The CT reported a 65% lesion, but the coronary angiogram only showed 55%, the other way around. The Society of Cardiac CT, of which I'm a fellow, recommends very clearly that you do not have a specific value of luminal stenosis. So just like the CORAD score, we have scores here: minimal, mild, moderate, severe, and occlusion. So when we say, look, this is 70%, whether it's 70 or 75 or 80 on a cardiac CT will make no difference. It's the same category of severe disease. Let's follow this very clearly. The decision about therapeutics are not based on 55 and 60, 70 and 75. No, there are other ways to predict like FFR, but this is how you have to go by it. Can you have zero calcium and yet lesions? Yeah, that's quite possible. That's quite possible. We presented a paper and we showed that 4.7% of individuals, but these are above the age, will have softer lesions, but you will not see anything here. What does this mean? That can coronary calciums be still utilized? Of course, certainly, because the number of patients who will have significant lesions in absence of calcium will be very low. They are not the one where you are going to do an intervention. This is the most important slide if I don't get time for this lecture. 4 images. 4 images which you are going to completely miss on angiogram. Angiogram is just going to see the luminal contrast. CT tells you this. What is it? A, the first image. Here is an artery, the first upper one, and the lower bracket ones shows the artery has undergone a vascular remodeling. I consider this very important when I do the CTs. This tells you this plaque is very lipid rich and can break open. On an angiogram, this may look conventionally a 30-35% what we call medically manageable insignificant lesion. On CT coronary, you have to give him 80 milligrams of statin. No way out. This plaque has to be stabilized. Second, if you find a very hypodense lucent area, those are plaques which are getting thrombotic. 3, if you see on an angiogram a contrast going like this is hardly a lesion, 30%, because the lumen is absolutely okay, almost 40%. But you see a spotty calcification. A large spotty calcification with a lucent shadow is a vulnerable plaque. And 4th, this is called as the napkin sign. You hang your napkin on a ring. This is the ring. You see a lucent area and the contrast. On a cut section of our CTs, if you see this, these are the 4 European Society of Cardiology defined vulnerable plaque signs on CTA. Please remember this. This will tell you which patients will do very badly. Here is a LAD disease, occluded artery, These are some of our pictures, but we try to carefully look at it, right? So here is a occluded artery. Here is the occluded artery on the CT also. So this is CT. Here is your image on the coronary CT. Here is your CT angiogram, LAD occluded. But why did I bring this forth? Look at this. This is a very lucent plaque. This has a thrombus. So when you see a very hypodense area, very attenuated area, it tells you there is a LAD thrombus. So look at the LAD thrombus, black curtain-like on section. This is something very useful. The last 2-3 minutes, we can also image the stents. Which stents are imaged? All of them which are proximal. Here is a very well imaged stent where the lumen is absolutely patent. Here is the neo-intimal hyperplasia. Do you see this? This is the neo-intimal hyperplasia that's occurring in a stent. And you also, before I go to that, you can also see a stent which is occluded. So do you see this stent which is occluded? Lucent area, a lucent area, a lucent area, black area, no flow going through it. Here are saphenous venous grafts, and you all know that saphenous venous grafts these days are very unpopular. In 5 years, they get fired. So here are the venous grafts occluded, and you can just see the small bumps there where the SVG grafts have been kept, right? We call it as the Newbin sign. This is the ghost shadow of a occluded SVG graft. The venous graft has got occluded. This is called a Newbin sign, a small little knuckle that is seen on the aorta. You can beautifully trace in CABG. CABG is probably one of the best indications that I personally like in terms of viewing it. And lastly, of course, here is a patient with a coronary anomaly. So what is that? The RCA is flowing between the aorta and pulmonary artery. So when the patient exercises, this patient gets angina, right? Here is one of my patients who was getting, this is way back, 5 years back. There was a kink where the artery went through the right coronary, and between the aorta and the pulmonary artery got kink. This patient who has a kink is something very important. This patient had angina. Patient was taken for a treadmill test, developed ventricular arrhythmias, STs were down. Angiogram was done, left-sided all normal. Right catheter could not get hooked on the conventional cath, so was fortunately referred for a CT. The CT tells you that this patient has got an anomalous coronary, and that's why she is getting angina. So these are the simple messages I wanted to give, that CT has evolved, slices have got better, breath holds have become lesser and lesser. Radiation is really going to be a time of the past now. Don't worry about it. Contrast nephropathy will continue to remain a little challenge. We try and use minimum contrast. You cannot get away with less than 55 ml. I don't see any images there. 60 ml to 80 ml is the usual convention that people follow. Never redo a CT on the same day, trying to push it twice just to get better images. No. It's very useful for vulnerable plaques with 4 signs, for evaluation of acute chest pain, rule outs, in COVID days to pick up ACS, stents, CABG, and coronary anomalies. Thank you for the patient hearing. I'll stop sharing my slides.
Thank you, Dr. Uday Jadhav, sir, for this admirable oration. Now we move to our second part that is very important, that is international speaker program part. And for that, I would like to hand over this session to our chairperson, Dr. Uday Jadhav and Dr. Subhapan Chaudhary, sir. Over to you, Dr. Jadhav and Dr. Chaudhary.
Professor Dr. Jadhav may take over the first part.
Yes, sir. Please go ahead.
No, you take over the first part.
Okay, so all right, thank you. So we have Professor Philippe Gabriel Steg from France, from Paris, who will join us today. He will speak to us about how to use antiplatelet agent in clinical practice. So we have the dual antiplatelet therapy. We had great papers that came up this year, and Professor Gabriel Steg has been on practically all those clinical trials. Are we shifting our focus from a dual antiplatelet to a single antiplatelet therapy? Is that the way our patients will be protected equally or better and with lesser bleeds? So over to you, Professor Steg, for your guest lecture. Thank you very much. Hiren,
yes, Doctor.
Professor
yes.
on.
Yeah, Dr.
Steg,
yes,
please.
Dr. Steg is. Yes, sir. Welcome.
Very good evening, Professor Steg.
Yes. So let me get to my presentation. Can you see my screen?
Yes, sir.
All right. First of all, I want to say I'm really delighted to be participating in the Connect meeting. It's been quite enjoyable, and I have to say enlightening from many aspects, including culture. Today, I'm going to discuss novel directions for DAPT use in coronary artery disease. These are my disclosures. And I will start by stating that the story of dual antiplatelet therapy started really with the prevention of stent thrombosis 25 years ago, when it was observed that combination of a thienopyridine in addition to aspirin was quite effective in preventing stent thrombosis, which was not prevented by aspirin alone, warfarin alone, or their combination. And that really moved the field forward and started interest in dual antiplatelet therapy. Rapidly, we went from stent thrombosis to ACS and post-ACS trials, which demonstrated the benefit of dual antiplatelet therapy and even potent dual antiplatelet therapy in ACS. It started with the CURE trial in non-ST elevation ACS, quickly followed by trials in STEMI with clopidogrel. And then we realized that there were important limitations to clopidogrel: slow onset, slow offset, variable efficacy, largely related to the variations in metabolism of what is essentially a prodrug that needs to be absorbed and metabolized by the liver. And finally, the level of P2Y12 inhibition that was achieved by clopidogrel was moderate. And that prompted interest in prasugrel, which is also a thienopyridine and a prodrug, but has much more efficient and rapid metabolism by the liver, or ticagrelor, which is not a thienopyridine and does not require in vivo biotransformation. And as I'm sure the audience is aware, two large-scale outcome trials, the Trident TIMI38 trial for prasugrel and the Plato trial for ticagrelor, demonstrated benefit of prasugrel and ticagrelor in ACS. Prasugrel was tested for PCI in ACS, demonstrating approximately a 20% relative risk reduction in CV death, MI, and stroke at the expense of an increase in 30% of major bleeding. Ticagrelor showed a 16% reduction compared to clopidogrel in CV death, MI, and stroke, with benefit that appears to accrue steadily over time. And of interest, there was also a 20% reduction in cardiovascular mortality with ticagrelor compared to clopidogrel in a broad population of ACS treated with PCI, medical management, or CABG. So that established the value of DAPT and even modern DAPT in ACS and DES. And then the next question that arose was, can we abbreviate DAPT duration after DES in order to obviate the side effects related to bleeding and the need for discontinuation? And a number of relatively small academic-led trials looked at a shorter duration of 3 to 6 months compared to the orthodox duration of 12 months or more. And their findings are summarized in this slide, and they generally show a reduction in major bleeding, a substantial reduction in bleeding, but no increase or no statistically significant increase in myocardial infarction. Now, that conclusion should be accepted with a grain of salt because these are small trials, they're open label, there were crossovers, they're non-inferiority trials, and the upper limit of the confidence interval for the efficacy effect is quite wide. Now, we've looked in retrospect at most of these trials and looked at the non-inferiority margin that was selected in these trials, and it's striking that the non-inferiority margin is actually quite large, although the trials were often designed looking at an expected event rate in blue, and the non-inferiority margin was set at a red bar, which seems to be quite smaller here. Often the observed event rate was not 10%, but 4, and therefore a non-inferiority margin of 4% represents not only not anymore 40%, but actually 100% increase in ischemic events. The second problem of open label DAPT duration trials is that there were substantial numbers of crossovers and loss to follow-up in these open label trials. And this is not true of all trials, but for most trials, you can note that the total number of outcome events in green, on which the interpretation of the trial is based, is often much smaller than the number of patients lost to follow-up and the total number of crossovers, which are not evenly distributed in open label trials. So there are really substantial methodological limitations to many, not all, but many of these trials. I'd like to point out that some of our own trials, the Optidual French trial, had these limitations, but I also want to point out that some trials, such as the Prodigy trial, actually is a very well performed trial with very few loss to follow-up, very few crossovers, and a large number of outcome events. Some of the largest shorter duration trials actually picked up a significant increase in the risk of myocardial infarction with shorter duration. For instance, here in the SMART-DAPT trial, there was a significant increase in the risk of MI when DAPT was discontinued at 6 months. So does this mean that longer DAPT duration is better? Well, there were also a number of trials that have looked at longer duration. The largest one was the DAPT trial that looked at patients who had received a drug-eluting stents 12 months before and were even free. And they were randomly assigned to stop or continue thienopyridine from months 12 to 30. And the co-primary outcomes showed a reduction in stent thrombosis, in relative terms quite impressive, 70%, in absolute terms only 1%, and also a reduction in MACE, in relative terms of 29%, in absolute terms 1.6%. Of note, there was a price to pay for this increased efficacy with an increase in major bleeding by approximately 1%. A second trial that looked at prolonged therapy is a post-MI high-risk population trial, the Pegasus trial, which enrolled post-MI patients with risk factors such as age, diabetes, more than one MI, multivessel disease, or renal dysfunction. And all patients received aspirin, and they were randomly assigned to placebo or 2 doses of ticagrelor. What's interesting is that this is truly a high-risk patient population with a 9% event rate at 3 years. Both doses of ticagrelor yielded similar risk reduction, 90 and 60 milligrams BID. Of note, there was again a price to pay in terms of bleeding with a approximately 1 to 1.5% increase in TIMI major bleeding, but fortunately no increase in fatal bleeding, RACH, or their combination. Of note, the 60 milligram dose was slightly better tolerated than the 90 milligrams dose, which is why this is the dose that was selected and approved by regulators. Now, how do we make sense of these apparently conflicting data? Well, first, the clinical context may be critical. If we're looking at ACS or high-risk MI patients, there may be a greater benefit of prolonged DAPT. This is seen, for instance, in this analysis of the DAPT trial, where you can see that the number needed to treat to avoid one event is much smaller in ACS patients than it is in non-ACS patients, whereas the number needed to harm to create one bleed is actually almost the same. Likewise, this is a meta-analysis of all the trials that looked at long-term DAPT for secondary prevention. And there's a reduction in MACE, CV deaths, MI, stroke, stent thrombosis, an increase in major bleeding, and no overall effect on non-cardiovascular deaths or all-cause mortality. The second subgroup of patients in which there may be benefit to prolonged therapy is diabetics. We saw this in the Plato and the Pegasus trials, and this is a summary of these trials, subdividing the population in diabetics and non-diabetics. And as you can see, there is a consistent benefit in diabetics compared to the overall population and non-diabetic patients. But the absolute risk is much greater in diabetics, who are truly at greater risk at baseline, as we know. And therefore, the absolute benefit tends to be larger in diabetics than non-diabetics. Does this extend to patients with stable coronary artery disease who haven't had an ACS or an MI? Well, until recently, we didn't have any data until we reported the results of the THEMIS trial, looking at CV prevention in patients with coronary artery disease and type 2 diabetes who haven't had a prior stroke or MI. This is a large trial of almost 20,000 patients, the largest randomized trial in diabetes to the best of our knowledge. To get into the trial, patients had to have established coronary artery disease defined by either a history of PCI, a history of CABG, or at least one coronary stenosis of more than 50%. And they were all receiving aspirin and were randomly assigned to ticagrelor or placebo. Again, this is a high-risk patient population. This is the placebo event rate, quite a straight line over 54 months. And there was a statistically significant 10% relative risk reduction. And therefore, the trial met its primary endpoint, CV deaths, MI, and stroke, is reduced by ticagrelor added to aspirin. Of note, the benefits appear slightly greater in patients with a previous history of PCI compared to the patients without a history of PCI. And there were reductions not only in the primary endpoint, but also in MI, in stroke, in acute limb ischemia and major amputation, almost a 50% reduction. And there was no reduction in CV deaths or all-cause mortality. Bleeding showed a significant interaction between history of PCI and no history of PCI, with less of an increase in bleeding in patients with a history of PCI. Note that there's an increase in intracranial hemorrhage in patients without a history of PCI, but no such increase in patients with a history of PCI. So it appears that patients with a history of PCI have a slightly more effective therapy, less increase in bleeding, and therefore they're likely to derive the best net clinical benefit. And indeed, when we looked at net clinical benefit, defined as irreversible harm events, on the ischemic side, all-cause death, MI, stroke, or on the bleeding side, fatal bleeds or ICH, there was a statistically significant interaction between patients with a history of PCI who derived a 15% net benefit, statistically significant, and patients without a history of PCI where there was no net clinical benefit. In terms of events prevented or caused for every 1,000 patients treated for 3 years with ticagrelor, for patients with a history of PCI, 15 events are prevented, no bleeding events are caused, and therefore there's a net clinical benefit of 15 events. In contrast, patients without a history of PCI have no prevention of ischemic events and only bleeding events caused, and therefore no net clinical benefit. If we look at how long after PCI is the benefit maintained, the point estimate and 95% confidence interval indicates that this is true for at least 6 years and possibly up to 10 years. Interestingly, this resulted in a recent change in the ticagrelor label by the Food and Drug Administration, which extended the use of ticagrelor to reduce the risk of a first MI or stroke in patients with coronary artery disease at high risk for such events. And what's interesting is that the FDA considered the totality of evidence, not solely Themis, and stated that while the use is not limited to type 2 diabetes mellitus, this is where the efficacy of ticagrelor was established. Now, typically, this is where I go into risk scores to point out that risk assessment may guide clinical decision-making. I didn't do this in the interest of time today, but I also think it's less interesting because the field has been literally put upside down by a series of randomized trials that reported in the last 12 to 18 months, indicating that long-term monotherapy may be the future rather than dual antiplatelet therapy. Our whole thinking for many years has been to say aspirin is the foundation therapy, and we add to aspirin diclopidine, then clopidogrel, then prasugrel, then ticagrelor. Maybe we should reverse our thinking and consider, do we really need aspirin? Does it add anything on top of a potent P2Y12 inhibitor? Well, that was tested in 4 large-scale outcome trials. The first one, the global leaders compared a conventional strategy in an all-comers PCI population of 12 months of DAPT using ticagrelor in ACS patients and clopidogrel in elective PCI, followed by 12 months of aspirin, to an experimental strategy of 1 month of aspirin and ticagrelor, followed by 23 months of ticagrelor alone. That trial did not meet its primary outcome. And although there was an interesting trend towards benefit in terms of mortality or non-Q wave MI, the p-value was 0.07, and the trial fell short. But then another trial, the STOP DAPT trial, looked at 1 month DAPT followed by clopidogrel versus 12 months of DAPT in patients receiving PCI. Unsurprisingly, bleeding was reduced with 1 month DAPT. But what's interesting is that there was no difference in ischemic outcomes. And indeed, the benefit was entirely driven by bleeding. A second trial, SMART Choice, looked at P2Y12 inhibitor monotherapy after 3 months versus conventional DAPT of 12 months. CV death, MI, and stroke were no different, but bleeding was reduced. And finally, the largest of these trials, the Twilight trial, looked at 3 months of dual antiplatelet therapy with ticagrelor and aspirin, followed by ticagrelor alone, compared to a conventional strategy of 12 months of ticagrelor plus aspirin. That trial showed very clear results. On the left, the primary outcome is bleeding. It was almost halved by ticagrelor monotherapy. On the right side is the efficacy outcome of death, MI, and stroke. And as you see, the point estimate is identical between the two arms, 3.9 versus 3.9. If we focus even on the highest risk subgroup of Twilight, patients with ACS, again, the ischemic risk was identical between the two arms, 4.4 versus 4.3. And finally, a couple of months ago at the ACC, the TICO investigators reported the results of their own trial limited to ACS patients undergoing drug-eluting stent, and again comparing ticagrelor monotherapy after 3 months to 12 months of ticagrelor plus aspirin. And again, the primary outcome was net adverse clinical events and showed a reduction in the primary outcome, almost 35% reduction, entirely driven by the 3 months monotherapy. And there was no difference, and there was no difference in the ischemic outcomes. In fact, if anything, the ticagrelor monotherapy arm actually had a lower event rate than the DAPT-based arm, indicating that there is no harm in giving ticagrelor monotherapy. It actually may save bleeding and prevent treatment discontinuations, which lead to ischemic outcomes. And so this used to be the 2017 ESC guidelines for DAPT duration after PCI, and they emphasize a duration of 6 months in ACS for all high bleeding risk patients, 12 months or more for patients who are not at high bleeding risk, and in stable coronary artery disease, 1 to 3 months, 6 months or more in patients who are not at high bleeding risk. I think there are 2 important additions to this guideline that will change probably very quickly. The first one is the demonstration that monotherapy with a P2Y12 inhibitor started 1 to 3 months post-PCI can actually be a very viable and attractive strategy, demonstrated in Twilight, Smart Choice, Stop DAPT2, and now TICO. And the second addition is that long-term post-PCI therapy with aspirin and ticagrelor is attractive in patients at high risk of ischemic event and low risk of bleeding, particularly for diabetic patients, as demonstrated in THEMIS PCI. So my conclusions are DAPT is the foundation of therapy after PCI, but is not solely to prevent stent thrombosis anymore. DAPT using ticagrelor or prasugrel is generally recommended in PCI for ACS. The duration of DAPT should be tailored to ischemic and bleeding risks. But we now learned that dropping aspirin 1 to 3 months after PCI may allow to maintain efficacy while reducing bleeding risks, particularly when using a potent P2Y12 inhibitor such as ticagrelor. Finally, in selected patients at high ischemic and low bleeding risk, such as diabetic patients, prolonged DAPT appears beneficial compared to aspirin alone. I'll stop here and I'll be happy to take questions.
Thank you, Professor Gabriel. That was a fantastic overview of the entire antiplatelet therapy which is available as of now. Thank you very much. It was very nice. May I ask a couple of quick questions to start with from my side, and then we'll take up the audience delegate questions also. So it's very interesting, as you said, that the ESC will probably update their guidelines with Twilight and TICO trials. But let's say if these patients have been stented for a left main, or there is a multivessel disease stenting, or there is a CTO which has been done, will you still recommend just stopping the dual antiplatelet after 3 months? That's first part. And second part is the TICO use the Biotronik sirolimus coated 2nd generation stent. Is it applicable to all stents?
So I think you're making a very important point. Number one, in Twilight, to get into Twilight, patients had to have both clinical risk factors and angiographic risk factors. So Twilight does not apply to a low risk population. in fact, to get into twilight, patients were proposedly selected to be at high risk of stent thrombosis and ischemic events, including left main, including complex multivessel disease, including long stents, multiple stents, and small vessels. And in fact, subsequent secondary analyses of subsets within twilight indicate that there is no heterogeneity, and the benefit and safety of discontinuing aspirin appears to be consistent across the various populations. So I think that's very reassuring. The second point is clearly a lot of our thinking regarding dual antiplatelet therapy has been driven by the prevention of stent thrombosis from the old days of the first generation drug-eluting stents. We'll remember 15 years ago, the scare we had in 2006 when reports started coming out of late stent thrombosis with the sirolimus-eluting stent and the paclitaxel-eluting stent. We all agree that second and now third generation drug-eluting stents, new polymer-free stents, and new generation stents have much lower rates of stent thrombosis. And I think that we now need to focus on the patient rather than the stent. The patient as a whole, and when we're giving potent antiplatelet therapy, it is to prevent stent thrombosis. It's also to prevent CVD, MI, and stroke. But we also don't want to cause bleeding because we know how bad bleeding is. And one of the first reasons bleeding is bad is that bleeding will prompt discontinuation of antiplatelet therapy. And so I think we need to take the whole picture rather than focus on the sole aspect of stent thrombosis. And from that standpoint, dropping aspirin 1 to 3 months after PCI seems to be a reasonable strategy, even in high-risk patients with the newer generation stents.
There are a couple of questions I see from the delegates I'm passing on. Number one is that, this from Professor Saxena, who is a colleague here, that can you substitute aspirin with clopidogrel in patients without coronary artery disease as a preventive strategy where aspirin is indicated? Let's say diabetic patient. Is clopidogrel as good as aspirin?
So we have one large-scale outcome trial. Unfortunately, it's 25 years old, so it was done in a different era. But the Capri trial compared head-to-head monotherapy prevention with aspirin and monotherapy prevention with clopidogrel. And as your audience will recall, there was a moderate but significant reduction in outcome events with clopidogrel. The reason this was not widely adopted and embraced at the time was the cost of clopidogrel. Now, 25 years later, clopidogrel is a relatively cheap drug, and I think it's a reasonable alternative to patients who cannot take aspirin for any reason.
And the third question is, what are your comments on using ticagrelor in patients of acute ischemic stroke? We have the Thales trial that came on. So yes, what do you think?
Yes, this is quite interesting. There have been a couple of studies now that have shown that dual antiplatelet therapy with clopidogrel and more recently with ticagrelor combined to aspirin in high-risk ischemic stroke, particularly patients who have ischemic stroke of suspected atherosclerotic origin, is associated with benefit. And recently, the Thales trial really showed a very, very interesting result of improved benefit. I think the jury is still out on what will be the optimal balance of risk and benefit, because in the stroke field, in slight contrast to what we're seeing in the coronary artery disease field, bleeding is even worse than what is happening in the coronary artery disease. Our neurology colleagues know how terrible intracranial bleeding can be, and the risk is higher post-stroke. So I think there is still a discussion as to what is the optimal balance. Is it clopidogrel added to aspirin or ticagrelor added to aspirin? I think the Thales results are really very, very interesting in that respect and will be discussed by regulators and guideline committees.
Thank you. Dr. Shubhankar, if you have any questions.
Not really. I mean, it was a wonderful disposition, very clearly enunciated, especially in relation to how long you should use and moving away maybe from the concept of just dual, maybe also to single antiplatelet for long term. So I'm fine. Thank you very much, Professor Steig, for joining with us from Paris.
It was a pleasure.
Thank you, Professor. Dr. Shubhankar, if you can take forward the next guest lecture.
Great. So it gives me great pleasure now to invite amongst us Professor Merlin Thomas, who is from the Monash University in Melbourne, Australia. And he is a researcher, an opinion leader, many of us may be so, but he's also a medical storyteller with over 300 publications to his name and best-selling books, The Longevity List and Fast Living, Slow Aging. He has, of course, several honors to his name, and his research interest is on understanding mechanisms of diabetic complications and evolving new opportunities for their prevention and treatment. For this evening, for us, but it's later, quite late in the night, I suppose, I'm sure, for Professor Merlin Thomas. He takes us through the issue of diabetic nephropathy, which we do understand has possibly not shown as much as improvement in terms of prevention compared to coronary artery disease. And so it remains a very important area, and he will be talking about, I'm sure, the conventional treatment and newer possible therapies upcoming. So over to you, Professor Merlin Thomas.
Yes, Dr. Merlin Thomas, please unmute yourself. Dr. Merlin Thomas. Professor Merlin Thomas, please unmute.
Professor Merlin, kindly unmute yourself and share your screen.
Dr. Merlin Thomas.
Would someone try and get in touch with him?
Yeah.
So, of course, we do understand, especially in our country, where health care is mostly through out-of-pocket expenses. Having someone developing chronic kidney disease to the extent of end-stage renal disease is really a difficult, a costly proposition. We have fewer centers to offer management of end-stage renal disease. We have, and wherever it's available, the cost becomes too much. And then the issues of kidney transplantation, how to get a donor kidney, and then again, the facilities, the number of centers to provide the facilities are too few. So we particularly, and also of course across the world, would particularly do everything possible to prevent the development of diabetic nephropathy. And I'm sure Professor Merlin Thomas will take us through this within the 20 minutes that he's provided with. There must be some connectivity issues. If Dr. Hiren would suggest that we go on to the next part of the program and maybe ask Dr. Merlin to come back, then we could make better use of the time, maybe start the first part of the panel discussion, if it's possible. Has anyone been able to get in touch with Professor Merlin Thomas?
Yes, sir. We are calling him. He's not picking up a call right now. So I think what we can do, we move to the next part, and later on we will cover his talk.
Right. So would then Dr. Jadhav take over?
Okay, sir. Sure.
Yeah.
Sure.
Yeah.
So let's go ahead and then start with our panel discussion for today. Let me quickly tell you who all are with us today. We have so this is really going to be a cross connect. Why is that? We have the faculties who have joined us from all over the country, right? So we have Dr. Vipin Talwar from Jalandhar, who is a diabetes specialist, Dr. Meenakshi Sundaram from Apollo Madurai, who is our senior consultant neurology expert. We have Dr. Alok Jain, who is the director of nephrology at the Birla Hospital in Jaipur. We have Professor Sandeep Saxena, who is the retina specialist from Lucknow. We have Chandrashish Chakravarti, who is the critical care specialist at Apollo Gleneagles, Kolkata. And I'm looking forward to ask him multiple things. And of course, in a little different way, Dr. Nilesh Shah, who is a senior psychiatry professor at the Sion Medical College Hospital in Mumbai, and our co-director, of course, Dr. Subhankar Chaudhary, to help us. So let me now start sharing the screen. And go to HF seminar. Share. Is it seen or not seen?
Not yet seen. Not yet seen.
Okay, okay. I will redo it. Share. Is it now seen?
Absolutely fine.
Thank you very much. So here is what I'm going to do. Ladies and gentlemen, you have heard enough of COVID. There's been so much COVID, and this is how webinars are going these days. This was the pre, and this is how webinars are today. We will not allow you to go to sleep. We have exciting interaction for half an hour. Stay put. What I'll do is I'll present one or two slides just to keep you focused on absolutely recent update on COVID. We need to get ourselves updated really, really well. This is the biggest challenge in clinical practice as of now, not just in Mumbai where it's just rampant, but all over the country. What I'll do is I'll start with my cardiac perspectives. Just 2-3 important things which I feel are new and relevant and important. Then we'll go to critical care. We will go to nephrology, neurology, diabetes care, and the psychiatric care. So let me go ahead and tell you something very important. You're all aware that in COVID, one of the important prognostic markers are the rise in troponin and rise in BNP. You do the troponin and BNP at the base, and then you follow it up. If you find an escalating value of troponins and BNPs, it tells you that these patients are going to do very bad. So it's a good prognostic marker. But what is it that new has come up in this week? This week is that they looked at patients who are not hospitalized, who are at home with what you call as mild to moderate COVID, and they were treated at home. When they came out of the COVID, after 2 weeks, 4 weeks, their cardiac MRI was done of apparently asymptomatic mild COVID, and look at what they found. There is a T1 and T2 MRI imaging enhancement, and if you look very carefully, there is an enhancement on the myocardium and the pericardium. This was found in 62% cases, and day before the newspaper in our country reported it, interestingly, of the likelihood that in future we may get patients now with heart failure, which apparently don't have anything beyond mild COVID. So we need to very carefully look at this burden of heart failure, unfortunately, which may come on our head in patients who are recently recovered from coronavirus disease. So that's first thing. Second, this has been one of the best JAMA cardiology publications in these COVID times. It talks about the autopsies. What happens to the heart? These are the first image you see of the SARS-CoV genome present in the interstitium. Here are the myocardial cells. It's outside the myocardial cells. So not only you have myocarditis that we know of, which is contributing so much to morbidity and mortality, but you will end up with patients of myocardial fibrosis, normal ejection fraction on echo in future, but heart failure with a preserved ejection fraction. This is the second important thing. And third important thing, which I thought I wanted to share. Here are histological images. So this is the first time we are seeing the presence of virus inside the myocardium. These are European Heart Journal ESC heart failure paper last month. Not only there is myocardial necrosis, first image, not only there are viral genomes which are seen, but if you look at the D image on the left lower corner, what we find is this inflammation goes through the arterial wall and ruptures the vessel. Here is the bleeding inside the capillaries. This is causing capillary thrombosis. Therefore, now you have those COVID, STEMI, non-STEMI mimics. Patients with COVID get an intravascular hemorrhage inside the vessel hemorrhage. They develop a thrombus. These are the patients who are only going to do well with medical management of COVID. We have burned our fingers trying to do PCI in these patients. Not only they don't improve, they actually do bad and they go in fulminant cardiac failure. So this is the only thing I wanted to share with you today on cardiac. Now let me get on with our infectious disease specialist, Dr. Chandrashish. Thank you very much for being with me. I am going to present 3 or 4 important slides because this is what I wanted to understand. We all know about mild cases. Now we want to look at how are we managing moderate to severe cases. I am trying to place this important drugs: remdesivir, tocilizumab, corticosteroids, and anticoagulant. Couple of important updates that have come. Remdesivir, this is a recent paper. It says should be prioritized for hospitalized patients who require supplemental oxygen. Those on ambient air may get some benefits. It's not really working for patients who go on a high flow oxygen or NIV or invasive mechanical. And it is not the number of days you count from the onset of symptoms, but how the diseases progress. I read the early paper of NEJM which said 10 days of therapy. Now we are coming down to 5 days of therapy. So that's about remdesivir. Tocilizumab. Couple of quick slides. Very, very recent slide. Today's publication, in fact, in Lancet about severe COVID. Here is what they are saying, that in the presence of high interleukin 6, if the saturations have dropped less than 93, if the ratio has been less than 300, importantly, in the previous 2 days of hospitalization, there is a 30% drop in that arterial measured oxygen, as we all see, and the FiO2, which we give with high nasal flow. Then these drugs works well. You give 2 doses. Now that's what I wanted your comment on, whether it should be 1 or 2. Here they say that the plasma levels may not be maintained on 1, so give 2 doses 12 hours apart. People have given 3-4 doses. We don't know what is what. Does it change mortality? So this paper looks at cumulative probability of mechanical ventilation or death. Here is death on the left lower panel. And as you can see, the blue arm tocilizumab did that as compared to placebo. So I did not have this mortality data before. I always thought it reduces the hospital stay. Will it reduce it? Third, a quick answer on dexamethasone. I thought this was very good. The recovery study which told me, and which I believe in, that 6 milligrams of Dexona daily will work in patients who are receiving invasive oxygen. 16% reduction. Mechanical ventilation, still more reduction. But not only no benefit, actually a harm in patients who don't require oxygen. So a lot of patients on mild disease or on steroids, should we give that? And lastly, for the critical care discussion, here is anticoagulant chart being just published, but how long we should give enoxaparin or low molecule or heparin? Should it be still discharged? Should we continue oral anticoagulant for 42 days, as some of the trials have mentioned? So, Dr. Chandrashish, please go ahead, explain us moderate COVID. How can we prevent them going to severe COVID? Thank you.
Thank you, Dr. Jadhav. So you have already mentioned about the drugs that we are using, which are tocilizumab and remdesivir and steroids. So as you rightly mentioned, we are not encouraging patients to be started on steroids if they're not requiring oxygen. There is also a recent paper which is showing that you can also do a CRP level along with it. And if your CRP is less than 100, then steroids may not be very useful. If it is more than 200, it's most of the time useful. Between 100 to 200 is a gray zone, which basically says that if your inflammatory load is high, steroids work better, which makes sense. The dose of steroids that we are using is before the recovery trial, we are using 40 milligrams of Solumedrol once a day. Currently, if you are using tocilizumab, we are still using 40 milligrams of Solumedrol along with it. The reason being there is some minor interactions with dexamethasone and tocilizumab. So we should not use both. In cases where we are, I'm sorry about tocilizumab, it's about remdesivir. So there are some interaction between remdesivir and dexamethasone. So that's why you use Solumedrol with remdesivir. Now, if you're not using remdesivir, then we use dexamethasone, but we use 8 milligrams of dexamethasone because that is equivalent to the dexamethasone of 6 milligram in the recovery trial, because the salt that we get is 8 milligrams. So that becomes equivalent to 6 milligrams of dexamethasone that is being used in UK. The advantage of using dexamethasone is that we really don't need to taper the dose as we want for Solumedrol over 10 days. And in the recovery trial also, they have used 8 milligrams for 10 days and then just stopped it. They have not tapered it. Now about tocilizumab, as you rightly said, that we have to pick up the patient when the patient is increasing their oxygen requirement, or they are moving from oxygen by face mask or nasal cannula to high flow nasal oxygen or non-invasive ventilation. This is the point where we need to find out if their IL-6 is high, if their CRP is high, and if they're showing other features of severe disease. And this is the point where tocilizumab should be used. Once the patient is on the ventilator or on very high support of NIV, tocilizumab usually does not work very well. Now, the question of that you have asked me is that whether you should give 1 dose or 2 doses. We have got 4 patients in which we had to give 2 doses. Obviously, if you are using 2 doses, that means the patient is sick. And among these patients, 50% of them have died. And they have died because of secondary infections, which is basically multi-drug resistant gram-negative bacterial sepsis, either causing VAP or causing bloodstream infections. So does giving 2 doses of tocilizumab in our setting increase their chance of dying from secondary bacterial infection is something we have to be careful. Also, we are finding a lot of candidemia in these patients who have received tocilizumab and steroid combinations. Whether it's because of toci or it's because of steroids, difficult to say, but they are having candidemia in some of these patients. So we have to, so when we are giving more than 1 dose of tocilizumab, we have to be really cautious about the amount of immunosuppression or secondary infections that it is causing. And sometimes after 2 doses, it can also cause thrombocytopenia, which may become a problem in certain patients, not in all patients, but in certain patients. Also, we have seen 1 patient in which the patient had a very prolonged ICU stay, received multiple doses of tocilizumab, 2 doses of tocilizumab, and then had a CMV reactivation disease and actually died from a CMV reactivation. So is tocilizumab responsible for it? We are not very sure, but we thought that we should report it, and we have sent it for a case report. So that is it. And the last thing about remdesivir, again, remdesivir, as you mentioned, is we are still not sure whether it changes mortality or, but definitely it should be used only in patients who are hospitalized. And the criteria for using remdesivir has all been laid down based on the fact that it was a drug which was difficult to acquire. Until now, it is difficult to acquire because the production is not that much. Therefore, most of the indications that have been mentioned or has been followed in the Western world has been, if the patient is on at least 4 liters of oxygen, then only they have started remdesivir. Below that, they haven't. Even if you look at the Boston protocol, Harvard protocol, it's the same. But you can argue that if the drug is freely available, then probably you can use it even earlier in hospitalized patients. So that's the way we are doing with it.
Okay, and your comment on the how long should we continue the oral anticoagulants given a high thrombotic load in moderate to severe?
Yeah, that's sorry, I forgot that question. So, so the current recommendations from the ACCP and Thoracic Society is that in patients who are not on ventilator or has not shown any features of pulmonary embolism by CTPA or a thrombus somewhere else, they have not recommended giving anticoagulation after discharge. However, we have got patients with multiple thrombotic manifestations. Like we had one patient who had an internal iliac artery thrombosis suffering from COVID, and there's no reason why she got it. We got a patient who developed an LA clot. We got patients who developed pulmonary embolism in the hospital. So these patients obviously needs to be discharged in full anticoagulation, and we usually prefer NOACs for these patients.
Okay, thank you very much. I think that's very well answered and covered. We could have you for 1 hour on this symposium because there is so much we get to learn from the critical care specialists. It's very important. All of us are involved in some way or the other. Thank you very much. Let me proceed with the renal aspects, and our colleague nephrologist will brief us on what does he think about how do we deal with this sort of patients. So we have Dr. Alok Jain with us. Just a couple of one slide on COVID and the kidneys. I mean, those patients, as we were discussing yesterday, patients who are at a high risk of COVID are actually those who go for a kidney transplant, or there is an immunosuppression issue related to it, or those who undergo hemodialysis quite often in the hospital have to come back, let's say alternate day where we have planned them. And then it's difficult to pick up COVID because of shortness of breath always, because they have it one way or the other because of a cardiorenal problem or a fluid load. So that's one. Does COVID actually affect the heart? Is there a COVID viral nephropathy in terms of direct tubular infection, as the ACE receptors are also there? And this was one of the slides that talks of how SARS-CoV-2 can lead to acute kidney injury. Over to Dr. Alok Jain, please put on your comments.
Yeah, thank you, Dr. Jadhav, and good evening to everybody. You rightly said that whenever a patient of COVID comes and he is having a severe infection, the kidney is the first organ to be compromised. And there are two series which have been described. One was from New York, where they have seen in around 5,500 patients that 37% of these population which had COVID infection were having acute kidney injury. And important thing which we should know is that 1/3 of the population which is getting AKI is occurring within 24 hours of admission. And out of this 37%, 31% of the population had a severe AKI, and 15% of these patients required dialysis. And the patient who required dialysis, 97% of these patients were on ventilator. So this is an important aspect which came from US, that kidney is one of the most important organ which is being involved in COVID infection when it is in severe form and the patient is on ventilator. Now, second thing which they said was the predictors, what can be there as far as AKI is concerned. It can be elderly population, the population who are Black, diabetic, hypertensive, those patients who are having concomitant cardiovascular disease, and the patient who are on inotropes. These were the predictors who were developing acute kidney injury. The same study was published from Italian Society of Nephrology also. This was published on 20th of July, just now only. It was on 3,300 patients. And they said that the incidence of acute kidney injury is around 46%, out of which 20% of these population were requiring renal replacement therapy. The question you asked was, what can be the proposed mechanism of acute kidney injury in these patients? Yes, you rightly said the first is that the virus directly, it attaches to the ACE2 enzyme, and then it attacks the proximal tubule cell and podocyte. And this is evident when electron microscopy was done, and we were able to find viral RNA in the cells of proximal tubule as well as on podocytes. So the direct injury by COVID-19 virus was one of the pathogenic mechanism, but it is not alone, it is multifactorial. The other factors which can lead to acute kidney injury is there can be a fibrin thrombi, which can lead to thrombotic microangiopathy. It can be because of cytokine storm. It can be because of hypoxemia. It can be because of multiple organ dysfunction syndrome, which occurs very commonly in patients who are having severe COVID infection. Now,
Dr. Alok,
yeah,
one quick question,
yeah,
because
yeah,
this comes after the critical care aspect, that when we use drugs like remdesivir or tocilizumab, and if the GFR has started getting impaired or there is a AKI,
yeah,
do you
yeah.
alter the doses of these drugs?
Yeah, very good question, sir. As far as remdesivir is concerned, the recommendation is that it should be used only when the GFR is more than 30 ml. Less than 30, it is not recommended, as well as on those patients who are on dialysis, it is not recommended, because the vehicle which is there in remdesivir is cyclodextrin, which is injurious to the kidney. It further precipitates the nephrotoxicity. As far as tocilizumab is concerned, there is no such recommendation. No dose modification is required at any point of GFR in patients of AKI. Now, what can be the treatment of AKI when the patient has and he is on ventilator? The role, what can be there when the patient is having a cytokine storm? So the modality which we can use is renal replacement therapy, either in form of CRRT or hemodiafiltration along with immunoadsorption. So this is the modality which is to be kept in mind or to be done in patients who are suffering from AKI, severe AKI in patients of COVID. And important thing is when to initiate the therapy. So the study says that you measure the interleukin 6 and D dimer, and if the interleukin 6 is more than 24.3 picogram and D dimer is more than 0.28 microgram per ml, because they have a very short half-life, so you have to measure it as early the patient is on ventilator or he's having pneumonia. And if the desired level is there of interleukin 6 and D dimer, keep the patient on CRRT with immunoadsorption. Stage 2 AKI, if you do the CRRT within 8 hours of development of stage 2 AKI, you will have a better result rather than the patient going into stage 3 AKI. So there were studies which was like ELAINE randomized control trial, which suggests that early initiation of CRRT has a better outcome. Then which volume ultrafiltration to be done? There are two types of high volume ultrafiltration or normal volume ultrafiltration. There were difference of opinion. Both had its pros and cons, but it depends on the population or the variety of patient you are dealing with, that you have to go for an high volume ultrafiltration or a low volume ultrafiltration. The third question you asked was about kidney biopsy. So there were two studies being done where they found out what happened in kidney biopsy in these patients. This was first from China, and this was on 26 patients of AKI where they did the kidney biopsy, and the most common finding was acute tubular injury. And this tubular injury was because of the fibrin thrombi. This was because of the pigmented tubular cast. This was because of the viral-like particles which was present or seen on electron microscopy. And this was in 7 patients out of 26 patients who had acute kidney injury. The second presentation which a patient comes with in in COVID-19 infection is patient can present with hematuria or proteinuria. It was found that around 40% of these patients can have proteinuria or hematuria. And the most common cause of this proteinuria hematuria was collapsing FSGS, which was present in around 6% of the cases. Again, there was a study published in JASN, which says that when a biopsy was done in around 14 patients, the most common finding was collapsing FSGS in 5 patients. Other had minimal change, membranous, or acute tubular injury. So renal biopsy also shows that there is a direct impact of COVID-19 virus in kidney, preferably or mainly on proximal tubule and podocytes. And this is leading to acute kidney injury, which mandates or requires renal replacement therapy. Now, the second question which you asked was on hemodialysis, the patient on maintenance hemodialysis. Those patients, you rightly said, they are breathless because of the fluid overload. But important thing to remember is that these patient does not present us to as fever, because this patient has very high BUN or blood urea, and urea being an hypothermic agent these patients does not present to us with fever. So there is no fever. The breathlessness we think is because of the fluid overload. So it's very difficult for us to diagnose that the patient is suffering from a COVID-19 infection. And that's why the mortality is very high in patients who are on CKD and having on maintenance. It's around 42% patients, if they develop COVID-19 because of the chronic inflammatory condition which a CKD patient has, they are liable or vulnerable to be having a high mortality. The third question was on transplant. Again, transplant patient, they are on immunosuppression, and if we go for they have COVID-19 infection, the mortality becomes very high. It becomes a double-edged sword, that whether to decrease the immunosuppression or to preserve the kidney or to maintain the human body. MMF is the drug which is to be taken off whenever a patient is having, or what we say, azathioprine and MMF. These are the two antimetabolites which has to be taken off from the prescription whenever a patient is suffering from COVID-19 infection.
Thank you.
Thank you.
Thank you very much. And so we have Dr. Sundaram, neurologist, joining us, and there have been a couple of very interesting publications that have come up. The question to Dr. Sundaram is there a difference in terms of patients of COVID who comes with strokes and the conventional strokes that a clinician sees in practice? Is it that they are more severe, the worse outcome, higher mortality? Is there a true infection of the virus as a direct vasculopathic effect? These were some of the symptoms reported. They look same to me as in other strokes: motor, dysarthria, sensory, middle cerebral artery. Is there a SARS-CoV in the CSF? And patients complain of lack of smell and taste, and I don't think these are just related to a coryza or the inability to appreciate. Is that the olfactory nerve actually gets affected? So these are some of the characteristics, and please brief us on how should we look at patient with stroke.
I'll go through the questions one by one, sir. Thank you very much for the opportunity. First, thank you, Intas, for inviting me for this symposium. I hope I am audible clear, sir.
Yes, sir. Yes.
Thank you very much, sir. So the first thing is about ischemic strokes. The presentations are no different. Whether they have COVID or non-COVID, they are absolutely no different. They are just the same. And the first question you have posed there, I can see, is that do they have higher, mortality and have worse functional outcomes? Probably that should be true, because they are going to have an added comorbidity to their list, which is actually COVID by itself. As for instance, if a patient has got a significant amount of infarction in the brain, they develop malignant infarction, they have respiratory disturbance, it's going to be very difficult for clinicians, as Alok was also talking about this. What is this breathless? What is this respiratory disturbance due to? How much is the COVID contributing to? And the dilemma will always exist, because there have been recommendations which are changing every day. The number of publications as of now about COVID have far exceeded the days which we are in lockdown. Every day recommendations have been changing. That means whether to intubate, not to intubate. We are going through really a crisis phase. And the uncertainty will exist also. And many patients, we saw especially in the early part of this pandemic, they're not coming to us right in time, because they are afraid of coming to the hospital because they think they will contract COVID. And then sometimes the elderly people, surprisingly, it's not recognized they had stroke also. They are now staying aloof and alone. Some people, a single parent would stay alone in the room and he would not be recognized that he had a stroke. This has happened more than one occasion with us. So overall, because of late presentations, there will be difficulty in treating these people. But the fact is that once they reach the hospital, the treatment modalities are just the same. There is no difference. Even if you look at the two important data regarding the stroke management, one which came from China and one which came from Barcelona, Spain. Now, Chinese data also showed that the patients who came for emergency care during this pandemic for stroke actually decreased. The hospital admissions decreased, the thrombolysis overall rates decreased. But if you look at the number of people who entered the hospital, how many were thrombolyzed, that did not change at all. That means our outlook to treatment is not going to change, especially the acute management, which is quite important in the management. That's going to change. It is how we are going to project it. Because it is a hyperthrombotic condition, sometimes we may face problems, because the conventional therapy, for instance, in the patient who has come outside the window of IV lysis, we go for mechanical thrombectomy. Fortunately, we have not come across this problem, no, but it is reported that patients, once you have opened the mechanical thrombectomy, following a mechanical revascularization, endovascular therapy, they go for reocclusion. So that becomes a difficult thing. In our small experience, we had only mechanical thrombectomies performed twice during this COVID. We didn't face this, but it is reported definitely. So those issues will also worsen the severity. The second question is about the viral infections you mentioned. That yes, viral infections trigger stroke. One of the etiologies of stroke is actually viral infection. Influenza virus was implicated even before the onset of COVID. Sepsis is associated with infections. So these things are very well known. So SARS-CoV is one of that. The direct vasculopathic effect has not been proved, however. That has not been proved. The third thing is about the stroke symptoms. They are just the same as I mentioned earlier. They are not going to change. The vascular territory obviously is going to be the MCA because that is the most commonly affected territory in stroke, and that is the largest vessel supplying the brain, and naturally it is going to be affected more. Regarding the CSF, that's a quite interesting question. The question highlights the point whether SARS-CoV can produce a meningoencephalitis hacking in the CSF. That's a very important point. As of now, the answer is not known, but there are some evidences. In one patient, there was CSF positivity in RT-PCR, and in another patient also PCR, it was not mentioned, it was RT-PCR, it was again positive. So probably it could happen there, and in an autopsy study, it was shown that in the brain tissue, it was stained and it turned positive for COVID among the autopsy studies. This is the published literature as of now, but still it is not conclusive. The reason is because the viral so-called particles, even they are not able to tell clearly, are they really artifacts? So if we are still in the gray zone, probably it should have a CNS infection, but we do not know. And the last question was about anosmia and ageusia. It's quite common. More than 2/3 develop this. The common explanation is actually a common cold only, but more than that, it can invade the olfactory tract as well. There is an interesting paper that has been published on the MRI abnormality of the olfactory tract going right away to the frontal gyrus rectus. The signal hyperintensity has been shown in that paper. So what it means is that the olfactory tract can be directly invaded and produces anosmia. So it should be quite common. In fact, it is one of the key symptoms which we have seen in our practice, that the patients now recognize and come to us. Because this anosmia in the previous common cold, they never came and told us. But now, because the awareness is so much, they come to us and tell us. And the ageusia, these are things which are seen. I think I have answered these questions.
Yeah, just a quick comment for time. Your comment on using heparin or enoxaparin in these patients upfront, in these patients of stroke who come with COVID.
Sir, heparin is used only in a very small subset of stroke patients as a treatment for stroke. It is widely abused, I must say, by left and right by all of us. It's not correct. In that subset where it is really required, there is no need to withhold heparin. You use the same common sense judgment you do in another patient. The use of heparin routinely, because a patient has got COVID, is also not correct. In an indication where it doesn't exist, you don't have to push it. You don't have to say no to a hospitalized patient where you use for DVT prophylaxis to say no because you've got a stroke. Both are not required. We must understand that the majority of the strokes are ischemic strokes. That is very well known to us. If you take roughly 1,000 patients with stroke, 4 of them will have 1,000 patients with COVID, 4 will have ischemia. But remember that of the 1,000 patients with the COVID, 1 will have hemorrhage also. And when you look at these hemorrhages in the brain, majority of them were hemorrhagic transformations, and frank hemorrhages happened after anticoagulation. We must remember this point, because the inflammatory pathway which is deranged, the cytokine storm Alok was talking about, the deranged pathway commonly produces thrombosis, but it can very well result in significant hemorrhage. So the routine use of anticoagulation just because a person has got COVID is not to be accepted. That is the available literature, willing to change if there is any fresh data. Thank you, sir.
Thank you very much, sir. This is very well answered. Excellent comments. I'm sure the clinicians who are listening will benefit a lot. This is something we need to carry forward in day-to-day understanding. We have a couple of other specialties with Dr. Subhankar. We have Dr. Vipin Talwar from who will also join us as a diabetologist and endocrinologist. Just 2-3 quick comments. Obesity is also important. I mean, we have started realizing, because the intensive care says it's difficult to put patient in prone ventilation when they become moderate to severe. I looked at this BMI chart and it looks so high in terms of the odds ratio of obese patient getting this problem. So it seems that the normal fat, when it becomes a dysfunctional fat, leads to so much systemic inflammation. So obesity is a meta-inflammation. That's the trouble which we get more in COVID. So your obesity, inflammation, infection, that's the road to the ambulance. So this is a real concern, Dr. Subhankar. And the other thing is, these two questions that clinicians often ask. Are people with diabetes at increased risk? You will have to let us know whether the evidence is really good. Maybe not as good, but they fare very badly once they get it. As you can see, the mortality rate is pretty high. They require more interventions, higher mortality, multiple organ injury, which we'll discuss in the next symposia also. And here is one of the therapeutic slides that you can consider stopping these medications during acute illness that can cause dehydration or drop in renal functions. Everything, sulfonylureas, metformin, even the SGLT2 inhibitors. Now, having said that, dapagliflozin, and you will take it up during your discussion also, DARE 19 has, the slide is not well seen, but it's enrolled patients with moderate to severe COVID. The way things can change in terms of reducing heart failure. So two aspects, obesity, how is it linked? How is it important? And how do we deal with diabetes and the drugs? Common, but very important question. Professor Subhankar, can you please take it ahead?
Right. So thank you very much. Very relevant. Obesity, I must say, if you look at the studies across the Atlantic, there seems to be opposing views. For example, obesity is so strongly related to adverse outcomes in US, but if you come to Europe, to UK particularly, it was shown rather those who were leaner were associated with bad outcomes. But this, of course, this issue in UK possibly relates more to the type of people who have got low BMI, maybe those who do not have access to medical care, who do not have proper nutrition. So it's not related to the obesity story per se, but other factors. So obesity definitely, especially high degrees of obesity, definitely a bad prognostic factor, and including practical issues of implementation of treatment, especially prone ventilation. Absolutely correct. But of course, we cannot do anything about it at that point of time. It's there, we have to accept, but we have to be possibly more aggressive. Maybe we will need more of anticoagulants in this group of patients. We will possibly require more anti-inflammatory treatment as well. The other issue about diabetes, of course, I think now more or less it's established that people with diabetes are not at higher risk of getting a COVID-19 infection. But if you get the infection and if you have got diabetes, there is again no doubt that you're more likely to develop. There's more need for ventilation and there is higher mortality. This also to an extent can be modified if the glucose control is better. Studies are very good studies are there to show that the in hospital also at admission glucose level is correlated with worse outcomes. The higher the glucose levels, the worse the outcomes. But what we do not have good data on yet is in hospital glucose management. What is the impact on the outcomes? It's expected, one would feel that better glucose control would lead to better outcomes, but on that point, we don't have very good studies yet. And one of the reasons, it's not just about glucose is what I feel, it's related to the underlying organ damage that the person with diabetes is also coming with when they get COVID. It's underlying cardiac dysfunction, underlying kidney disease, and also underlying lung disease. It's which less talked about in terms of complications of diabetes, but that's also affected in diabetes. So those are sort of unmasked with the sort of the attack of the COVID.
Dr. Subhankar, a quick question. The critical care papers, there's so much interest in they are saying insulin or even the basal insulin glargine have some role as anti-inflammatory agents. Do they play a fundamental role also besides just controlling sugars?
I would not feel so. I mean, they do have, but not a pharmacological anti-inflammatory role. I don't think so. But it's, of course, in the critically ill patient, that's the best way to go about it. Do not have other ways to control the glucose. So we have to have insulin. And in terms of these medications, yes, and very interesting about the study on dapagliflozin. I personally would feel, I mean, this is absolutely a pharmaceutical designed study. I have my personal reservations about the utility of the study, and especially in an acutely ill patient, we would definitely like someone to withhold SGLT2 inhibitors. I wouldn't like. So I would wish them best of luck, but I do not foresee great outcomes out of that study.
So we did exactly that, because this just did not go through the ethical committee first meet itself, getting dapagliflozin in so sick patients. Because
I can see Professor Merlin Thomas. So would you like to comment on this dapagliflozin in COVID study? Quick one.
Well, thank you for the opportunity. I think that it's really exciting that that drugs are being tested against COVID-19. The likelihood of it being antiviral is small, and the likelihood of it stabilizing the unstable hemodynamics associated with the cytokine storm are small. Nonetheless, I think it's worthwhile testing the effect it has on lung fluid, and maybe it will have some small effect. I don't think it's deleterious in any respect at all compared to other agents that might be deleterious in that setting, causing hypoglycemia or other kinds of issues. So I don't think it's going to be the solution that we all want, but I think it's worthwhile testing nonetheless.
Thank you. Dr. Subhankar, anything else? Otherwise, a quick comment from our psychiatrist, Professor Dr. Nilesh Shah, who is joining us for telling us,
yes, sure,
how does he think about this COVID? I mean, he was telling me that a lot of people have this COVID phobia and go on testing repeatedly with every small symptom. So that's one part. And how does he look at patients of the same family getting hospitalized, and how can the clinician support these patients? Dr. Nilesh Shah, please.
Can I also add something? It's
yes,
a
sir.
phobia. It's amongst the medical profession as well. You are well aware that many people in the medical profession are being affected. We have many fatalities happening. So what do we do? So do we sort of cloister ourselves? We stop our clinical practice? How do we go about it? And there is really a lot of concern amongst the medical profession as well. So how should we counsel ourselves? Yes, Professor
Nilesh Shah.
Yeah, thank you very much for giving this opportunity, and I'm very happy to be over here. And I will try and address both the questions. One is about COVID phobia. Basically, irrational fear with avoidance behavior is a phobia. So one has to understand that whether the anxiety associated is rational or irrational. Now, all of us are worried. I'm myself also worried. And for those who understand Hindi, earlier when we used to say, gale mein khich khich, gale mein kya karum? The easy answer was, Vicks ki goli lo, khich khich dur karo. Nobody was worried. But now, if somebody said, gale mein khich khich, gale mein kya karum? Our prompt answer is, mujhse dur raho aur COVID test karo. So now what has happened that all of us are anxious. Even I was anxious and I stayed home for 17 days and did not go to hospital because I'm 55 plus and we were asked to stay home. So here we differentiate between normal physiological anxiety and abnormal pathological anxiety. You have to be anxious because if you are anxious, you will take all the precautions. And earlier we talked about SMS. So all three SMS precautions must be taken by all of us. And for that, anxiety is good. It's a healthy anxiety. If you are not anxious at all and a kind of bindas attitude, mujhe kuch nahi hone wala kind of thing, then you are at higher risk of developing this illness. And that's why it is very, very important that we all have healthy, normal anxiety, which helps us to take all the precautions. Now, the same anxiety is overwhelming, excessive. At that time, what happens that we get symptoms, florid symptoms of anxiety like insomnia, preoccupation with these thoughts. It interferes with our attention, concentration. We are not able to do the work. So you have physical symptoms like palpitation, tremulousness, excessive sweating, and all the time you are worried about yourself, not only yourself, but your family members getting COVID. So now it has become pathological anxiety. And as you rightly said, that patients, I work at Sion Hospital, and we get large number of patients from Dharavi, are hardly worried about their problem. They are more worried that when their report will come and when they will get food and when they will go home. And as you rightly mentioned, the medical professionals, the healthcare workers were more worried and kind of calling us and saying, "Mujhe neend nahi aati hai, mujhe ghabarahat hoti hai." So if there is a pathological anxiety, we do two things. One is what we call cognitive therapy, behavior therapy, and second is medications. In cognitive therapy, we explain that yes, try to differentiate between probability and possibility. Yes, it is possible that you will have severe COVID infection. Yes, it is possible that you will have cytokine storm, and there is a possibility that you will have to go on ventilator. And yes, 1% or 3% chances are that you may die. But probability, look at the probability. If you take proper precautions, then the chances are that you will not develop COVID infection. Even if you develop, 9 out of 10 people will develop mild infection and may not require even any treatment. And many of them are asymptomatic. And even if you develop, majority, 97% recovery rate, only 3% will die. So at cognitive level, we kind of tell them that, yes, all the possibilities are there, but the probability are very less. Number two, we teach them relaxation therapy. So Jacobson's deep muscle relaxation therapy, pranayam, savasana, our old yoga techniques, any kind of relaxation will be good to reduce the anxiety. And basically, we feel that any person who becomes over anxious, excessively anxious, it's because of serotonin deficiency. If you have less serotonin in the brain, then probably you will be able to not deal with the current situation. So what we call SSRIs, serotonin selective reuptake inhibitors. So escitalopram is one of the medication which we prescribed. 5 to 20 milligrams is the dose. And this medicine increases the serotonin level in the brain, and it improves our ability to cope with stressful situations. So our ability to cope with stressful situation improves, and our ability to deal with stressful situation also improves. And along with that, many of us, because SSRI will take little time, 2 to 3 weeks, immediate effect, we give benzodiazepines, very safe benzodiazepines, which even can be used in COVID patients. Our atizolam is twice a day, 0.5 milligram, or clonazepam 0.25 to 0.5 milligram, and that reduces the anxiety. So patients presenting with severe anxiety, mental health professionals, our own doctors presenting with severe anxiety, with cognitive therapy, behavior therapy, and medications, we treat them. And we take care of this COVID phobia also. The second question is that when both husband and wife develop the anxiety, then what do we do? And this is a difficult situation, obviously. But again, I would do the same thing. One is that I will assess the level of anxiety, whether it's a physiological normal anxiety and whether they're worried about a particular event. They might be worried about their job. They might be worried about their children. They might be worried about some property matter. And can we help them out in this real anxiety situation? Or if it's a pathological anxiety, yes, cognitive therapy, behavior therapy, and medications, appropriate use of medications. And as I mentioned, even in COVID patients, you can use COVID patients with severe anxiety, you can use escitalopram, you can use lorazepam, clonazepam with due precautions.
Thank you very much, Dr. Nilesh. It's very kind of you. Very nicely explained as to how we look at these patients and we deal with it. For constraints of time, thank you very much. We end the COVID panel here. I'm handing it over to Subhankar Chaudhary for taking further Professor Merlin Thomas' talk, as well as the discussion further on multi-organ dysfunction in diabetes. Dr.
Just
Subhankar,
one
please.
comment, sir, if your permission. Just 1 second comment, that's all.
Yes, yes. Go ahead, please.
There is a paper published on 22nd July in JAMA, which says COVID phobia is a cardiac risk factor.
Oh yeah, maybe yes, of course, because it can trigger various things, including angina and arrhythmias. We know that. So yes, it has to be a risk factor. I cannot say it otherwise.
Can I just add one thing?
Yeah.
COVID phobia is nothing new. Earlier we had HIV phobia when HIV came, and earlier to that we had cardiac neurosis, cardiac attack, heart attack phobia. Before that there was a cancer phobia, and in 50s you had tuberculosis phobia when TB was a new illness and we did not have many medicines. So phobia keeps on changing. It comes under the rubric of illness anxiety disorder or illness phobia.
Yeah, but this is worse because we have phobia and we have cardiotoxicity. Thank you very much, Dr. Subhankar.
Thank you. Thank you very much, and a warm welcome once more to Professor Merlin Thomas. I'm sure it's quite late in the evening. It's past midnight. Thanks for staying with us. Once again, we would like to introduce Professor Thomas, who is a clinician scientist and program leader in the Department of Diabetes at Monash University in Melbourne, Australia. He is a researcher, he is an opinion leader, and he is also a medical storyteller who has more than 300 publications to his name as best-selling books, The Longevity List, and so on. And his research interests lie in understanding the mechanisms of diabetic complications and developing new opportunities for their prevention and treatment. Over to you, Professor Merlin Thomas, to talk us on diabetic nephropathy, its management, current and future.
Well, thank you again for the opportunity to speak with you this evening. It's a real pleasure to be back in India, although not personally, but being able to communicate to you. You've been recently hearing about the challenges of COVID-19, but it pales into insignificance when you think about the challenges of diabetes. I mean, the number of people in the world, we're talking about 500 million people with type 2 diabetes, and almost every second patient that we're seeing now in most hospitals has got diabetes as a complicating part of their illness. And of those people, chronic kidney disease in them is a major issue. So what I'm going to do is I'm going to share a little bit of a talk with you. I'm going to share my screen and tell you a little bit about our approach to diabetes. Just 1 second. So diabetes really is a major issue, but the real challenge is kidney disease. Let me just see if I can get this going properly. Oops, there we go. So if you look at the global burden of diabetic kidney disease, almost 1 in every second individual has got diabetic kidney disease. So that is, if you like, in the yellow circle overall, representing those people with increased albumin in their urine. And so this is 1/3 of individuals on average have got increased amounts of albumin in your urine. In the blue circle, you see those with a reduced eGFR, and that's roughly 1 in every 5 to 1 in every 4 individuals that you see. And so by the time you put that together and look at the numbers outside those circles, it's relatively small. So maybe a half or even less than that actually are free of diabetic kidney disease. And the presence and severity of diabetic kidney disease is a major predictor of adverse outcomes. Obviously, end-stage kidney disease is one of those, but there are other other issues as well in terms of adverse drug reactions, heart failure, end-stage renal disease, obviously, major acute events, sudden death, and of course, premature mortality. And it's interesting when you look at the American data across patients with type 2 diabetes, in the general population, those with type 2 diabetes on average have an age standardized mortality that's roughly 4 times higher than that of the general population. for whatever reason. And of course, COVID is one of those reasons as well now. But interestingly, when you look at those individuals who have got diabetes but no albuminuria and no reduction in EGFR, their age standardized mortality is roughly the same as the general population. It's those individuals with albuminuria or reduced EGFR, or particularly both, that have got this increased risk of mortality in the setting. And you can do the same analysis for MI or infections or whatever. It's the same overall. So the presence and severity of chronic kidney disease is a big predictor of adverse outcomes. So I've been asked to talk tonight a little bit about how you protect kidneys and prevent people getting into that situation where they've got renal failure, in particular end-stage renal disease. And obviously individuals with impaired renal function are most likely to benefit from renal protection, but it's not just them. It's those people who are likely to develop impaired renal function that are just as likely to be benefiting from renal protection. And these would be those who are fastly losing their kidney function. So on average, you're supposed to be measuring GFRs regularly in patients at risk for chronic kidney disease. And if you're losing more than 10 mils per minute per 3 years, so let's say 3 years ago, the EGFR was 80 and now it's 70, then you could say they've lost more kidney function than they should have. Therefore, they've got a risk of progressing to kidney failure and are worth renal protecting. Equally, those individuals with a normal GFR who have got albuminuria, poorly controlled diabetes in terms of blood pressure, and in particular other comorbid complications are at risk of developing renal decline. And so the question that I've been asked really is, how should we protect their kidneys in this day and age? And obviously there's a number of things that we can do and do currently that are quite onerous, that are quite difficult. But sadly, that they don't do very much to progress, to prevent the decline in kidney function associated with diabetes. So for example, lipid lowering is very important in patients with diabetes, but it does very little for progressive renal decline. I mean, it reduces major acute coronary events, it uses MI and death and all those other things, which is the reason that we put people on statins. But of course, when you look at declining in renal function, the rate of change in GFR, statins are not enough to prevent renal decline. So you may avert a heart attack only for the patient to end up on dialysis. Intensive blood glucose control, of course, has been our standard approach to sparing the kidney from the burden of diabetes. But actually, when you look at the data, the number of people in clinical trials of glucose lowering that develop either a doubling of serum creatinine or end-stage renal disease is really not altered by intensive glucose control. And even if you say, well, this is because we didn't have enough time. Maybe if we waited in the long term. Well, if you follow up the people, for example, in the Accord trial, in this example, they followed them up and yes, lowering, continuing glucose control over that initial period, following that 4 years later, yes, they're still less likely to have albuminuria, but their rate of doubling of serum creatinine, their rate of renal failure was not altered within essentially 7.5 years. And so you may have to wait 20 years to benefit. And most of our patients with renal impairment or at risk of renal impairment don't have 20 years to wait for you to get something right in terms of their kidneys. Of course, aggressive treatment of blood pressure has for a long time been thought of as a very important thing in patients with chronic kidney disease. And indeed, more so in patients with chronic kidney disease, where we've been recommending even more intense blood pressure targets, even below 130, in order to improve their risk of renal decline. But when you look at the rate of change of GFR that you see here from the ADVANCE trial with perindopril and indapamide, a lovely combination that has cardiac effects, look at the effects on renal function. There's none. The rate of decline of renal function is really no different from that of placebo. And when you look at the Accord trial, which took an even more aggressive approach to get people down below 130, thinking below 130, at least you'd protect the kidney, Actually, you had the opposite effect. Those people who were intensified aggressively had a greater rate of decline in kidney function and were more likely to double their serum creatinine or end up on dialysis as a result of therapy. And similar results were seen in the SPRINT study when non-diabetic individuals were introduced to low blood pressure lowering. But there are some things that we can do. We know blockade the renin-angiotensin system can have some effect on the ability of patients to slow their renal decline. And when you look at trials that have been done specifically in patients with diabetes and very heavy levels of proteinuria, you see that in IDNT and RENAL, there is a reduction in that risk, relatively modest, but significant overall. But have a close look at this. This is the rate of change of GFR when you use losartan in a clinical trial in patients with heavy albuminuria or proteinuria. There's really not much difference. And the difference is relatively small, maybe 0.6 mils per minute per year. And if you look at this trial and you extend it out down to the point that they got on dialysis, you would say, well, it may be delayed dialysis for a year, maybe even less than that. Actually, it's 9 months in the trial setting because they started from an eGFR of 40. So it's not enough to say this is a really game-changing, although this is our standard therapy that we have. Obviously, there are newer agents that block the renin-angiotensin system a little bit better. It's worthwhile noting that a recent trial was announced, the Fidelio diabetic kidney disease study, that suggested that the mineralocorticoid receptor antagonist finerenone was able to prevent the progression of diabetic kidney disease. We haven't seen the results yet, but it's just been announced, but certainly that's something to watch out for. So maybe there's other things we can do. Maybe there's diet and weight loss and lifestyle, but even the 10 years of hard slog associated with Look Ahead really did nothing for doubling of serum creatinine or development of diabetic kidney disease, and really had only a modest effect on an eGFR incidence of less than 45. So none of these things really make the kind of difference that we want to slow patients from developing renal failure and keeping them off dialysis, or in particular, keeping them from dying from renal failure. But maybe if we do it all together like you do in your clinical practice, maybe if you are aggressive with all of these agents, you'd make a difference. Well, this has been studied in the STENO2 trial. And if you look at the rate of change in GFR in the STENO2, yeah, there is, over a number of years, a legacy of getting good glucose, blood pressure, lipid, smoking, exercise, all the rest of those things. But the legacy is small, and the difference only comes out after 10 years, and difference is maybe 0.8 mils per minute per year. So it's a very small difference that you're garnering very late on, but it's still worthwhile looking for. So in this day and age, we have to think of new ways to protect the kidneys. And the nice news is that the guidelines both in India and globally now say that we should prioritize the use of agents that have been shown to reduce chronic kidney disease progression in those people with or at risk of chronic kidney disease. And there are now agents to show conclusively that they do that. This is not DP4 inhibitors. DP4 inhibitors are great for glucose lowering, but when you look at the effects on GFR decline, they are modest, and if anything, in the TCOS trial, sitagliptin caused greater GFR decline than placebo. It's not really GLP-1 agonists, although there was some difference in the RECORD trial with dulaglutide, looking at the changes in GFR, looking at the major reductions in GFR. When you look at the rate of change of GFR across these trials, GLP-1 agonists, either dulaglutide or liraglutide, did not slow the rate of change of GFR. And when you look at REWIND, this was the data I mentioned earlier, there was perhaps some differences in the decline in GFR by using a GLP-1 agonist, but it wasn't very significant. By contrast, it's very clear that SGLT2 inhibitors have a major and significant effect on the rate of change of GFR. This was the first study to show at the EMPA-REG outcome trial, where those in receiving empagliflozin in the red bar that you can see, there's an initial drop in GFR, but then subsequently it plateaus. and when the drug was removed, the GFR essentially bounced back to normal, whereas the placebo had declined and declined over time. And obviously, the rate of decline in kidney function is greater in those people at risk of renal decline, such as those who have got increasing amounts of albumin in their urine. And you can see in the gray there, those with macroalbuminuria declining at maybe 6 mils per minute per year, those with microalbuminuria, 2.5 mils per minute per year, and those without an albuminuria, usually 1 mil per minute per year. But those in the red treated with empagliflozin clearly have a different trajectory, where the change in GFR is flattened or slowed in the case of macroalbuminuria. The trials also show something very interesting, and this is worthwhile knowing, that when you look at the rate of change in GFR here in the placebo group, they were losing on average 1.8 mils per minute per year. So about 2 mils per minute per year overall, with some people losing more and some people losing less. Now, if SGLT2 inhibitors were just treating those sick people who are declining fast, what would happen is that the curve would bunch up. But instead, what's happened is that the curve has shifted, in your case, to the right, where the average GFR decline now is not significant, or only 0.3 mils per minute per year. And that's important because what you're seeing is not only less people declining fast, but also more people improving their kidney function while using an SGLT2 inhibitor. This is not just helping people with kidney disease. This is preventing people from developing it in the first place. So when you look at the fast decliners, those who are losing, let's say, 3.3 mils per minute per year, or 10 mils over a 3-year period, or 5 mils per minute per year, in other words, 10 mils over a 2-year period, all situations, a two-thirds reduction in the incidence of a declining kidney function. 2/3 less likely to lose a lot of kidney function in any treatment period. And obviously this then manifests when you look at other outcomes like doubling of serum creatinine, initiation of renal replacement therapy, or a composite of the above, to a reduction of nearly half in that outcome. This isn't a small decrease. This is a half less likely to end up on dialysis. The only trial currently to show us that this actually works as a primary outcome was the Credence trial that looked at canagliflozin, another SGLT2 inhibitor, but then said, well, we're not going to do a cardiac outcome trial, we're going to do a renal outcome trial. Let's look at these agents and see how they protect people who have got large amounts of albumin in their urine and a slightly reduced GFR, because we know these are the people who are likely to lose kidney function at a great rate of knots. And in fact, when you look at the yellow line here, the placebo's losing around about 4.6 mils per minute per year. Interestingly, exactly the same as the Renal trial in terms of the rate of loss of GFR, albeit from a slightly higher baseline. But you see what the canagliflozin treatment did in blue. It slowed it down significantly, down to now 1.8 mils per minute per year. And you might say, well, what do these numbers really mean for my patients? What can I tell them? Well, if you imagine that slope continues down, down, down to the point that they reach, let's say, an eGFR of 10, or the point that they'd need dialysis, you're looking at, if you started with an eGFR of 56 on average, you'd have, with an SGLT2 inhibitor, at least 10 years off dialysis, which is an extraordinary change. It's not a little bit. This is a big change in the risk of these patients ending up on dialysis. And of course, should you start these agents earlier, which of course you're able to do in your country, when they've got proteinuria in their eGFR is 70, the number of years that you could put on their kidneys and their lives is considerably more. The earlier you start these agents, the better the protection in the long term that you're going to receive. By comparison, this is the Renal trial. This is losartan and placebo. And you can see, although starting from a lower baseline and running very parallel to the placebo group, in the Credence trial, there was only 9 months off dialysis. So this is bigger than RAS blockade overall. The other really exciting thing about SGLT2 inhibitors is that they work categorically in the real world. This is recent data from CVD-REAL 3, following up the GFR measurements in patients, tens of thousands of patients in the real world population. You see that initial dip in GFR, but then subsequently stabilizing while other ones are declining because of background risk factors overall. And when you look at these individuals, it doesn't matter whether they had poor glucose control or good glucose control, a low GFR or a good GFR, cardiovascular disease or any other kind of background therapy. The blue bar shows you decline your kidney function, the placebo on the in standard therapy. The red bar goes, if you add an SGLT2 inhibitor, you're going to see a better kidney function overall. And the real world data, moreover, very clearly shows that the risk of developing, in this case, doubling of serum creatinine or end-stage kidney disease is reduced by half. Imagine that, half less likely to end up on dialysis or double serum creatinine. And obviously, this is not essential for everybody. Not everyone is at high risk of kidney disease. You know who's at high risk of kidney disease? Those who've got a reduced eGFR, or those who've got signs that their GFR is declining at a fast rate, in other words, more than 3 mils per minute per year, or those with albuminuria, poor control, other risk factors that say they're going to get into trouble. In them, you can say, I'm going to use this agent, and I know that it's going to reduce their risk by about half. And this is why current guidelines that are around the world are recommending for anyone with type 2 diabetes, CKD, or risks for CKD, that SGLT2 inhibitors are used to delay the risk of CKD progression. The exciting thing is that what will happen now in the future outside of diabetic kidney disease. And currently, there are a number of studies going on, the first of which is DAPA-CKD, that took individuals with diabetes, but also other forms of chronic kidney disease who also had albuminuria and a modestly reduced GFR, the kind of Credence patients, except now non-diabetics as well, and followed them up looking for a change in the reduction in kidney function or renal death. What's really exciting is that some of you will know that this trial was stopped early because of overwhelming efficacy. Now, Credence was stopped because of overwhelming efficacy. This one was stopped for overwhelming efficacy. The last time you saw 2 trials in the same space being stopped for overwhelming efficacy were the stoppage of Jupiter and the Ascot lipid trial as well, because it was clear that lipid lowering compared to placebo was obviously beneficial. Now, it's very clear now that SGLT2 inhibitors are going to change the way we look at chronic kidney disease, and in particular in the setting of diabetes. So no longer do we need to be afraid for our patients, knowing that we would struggle to work very hard and the gains would be really small. When we see risk for chronic kidney disease in patients with diabetes, there's now good evidence that there are therapies available to protect their kidney that are well tolerated and efficacious, that are really going to change lives as well as costs for patients with diabetes. And with that, I'm going to stop sharing and I'll leave it there. If there are any questions that you have, I'd be happy to answer any of them. Thank you.
Thank you very much. That was a wonderful talk, and actually ended on a promising note, hopeful note, that we'll be able to save many more kidneys in people with diabetes with the use of SGLT2 inhibitors. I would like to go back and ask you about the role of glucose control. You did show overall glucose control itself does not protect or prevent kidney function from declining. But if you look at the early UKPDS, it did suggest, so is it that when you start your glucose control, whether it's early versus late, does that make a difference, you feel?
That's an important point. I think that when you look at, for example, in type 1 diabetes and look at the trajectory of GFR from the DCCT through to EDICT, essentially the trajectories of eGFR are exactly the same, although the incidence of an eGFR below 60 and renal impairment was significantly reduced by intensive glucose control, but it took some years before that that develops. So I still believe that glucose control has an important role to play, but mostly to create a long-term legacy of good kidneys and good cardiac health. I think it's a prevention model. I think that what we find is that many people, by the time they've got chronic kidney disease or cardiac disease, or the kind of people that end up in trials that we've been looking at so far, really it's really hard to undo the legacy that they've already got. They've already got what we've been calling bad metabolic karma, and there's no way to change that. What you have to do is do something completely different, to actually use a therapy to change their kidneys. It's hard to undo the hyperglycemia that you've had for decades, but you can protect the renal decline. Even in credence with very late stage disease, you can slow the chances of them ending up on dialysis, but more particularly the fluid overload events and the other dysfunction associated with renal disease, which are often problematic in the clinical setting.
Right. And I would like to ask another question that's related to hypertension management. So blood pressure control, we all know, is important, though despite possibly a lack of evidence that itself leads to better kidney protection. In this context, do you feel in an individual with type 2 diabetes, is hypertension only no renal disease detectable at this point of time? Would you still go for a RAS blocker, or anything else would do?
In the absence of heavy albuminuria, the data for RAS blockade beyond other kinds of therapies is modest at best and probably not significant compared to the utility of blood pressure lowering. In someone with proteinuria or a already reduced GFR, I would say absolutely. But in someone with microalbuminuria, I would say the best important thing is to find a blood pressure control regimen that your patient will afford, will take, and keep taking, because the best therapy that isn't taken is the worst therapy. I think that we find that the advantage of things like angiotensin receptor blockers is that they're extremely well tolerated. And that's really their key advantage in this setting. Targeting a blood pressure of less than 140, I think, is entirely adequate in patients with chronic kidney disease. I don't think that there is real utility in going below that. And in fact, a meta-analysis that was done suggested that targeting lower blood pressures was potentially associated with increased risks, with the exception of stroke, which was reduced, but increased cardiac and mortality risks. So I wouldn't go much below targeting 140, which I think can be achieved by most agents, but RAS blockades in particular advantageous in patients who have got cardiac and or overt kidney disease.
Right. Finally, maybe a question about when you talked about the mineralocorticoid receptor antagonist and their favorable effect. Many patients who already have got diabetic nephropathy of some degree would have been on an ACE or ARB. So would you be happy to add a mineralocorticoid antagonist on top of ACE and ARB? I mean, given our experience with the use of ACE inhibitors and ARB together.
Yes. So the finerenone trial actually mandated that there was a background RAS blockade. So it's really interesting to see. I haven't the results aren't published yet, but they've just been announced to the in a press release. I think it'll be very interesting to see what's gone on there. What is very clear is that standard mineralocorticoid receptor antagonists, when used on top of standard RAS blockade in diabetic patients, particularly in patients with chronic kidney disease, can cause big problems. And the best example was what happened off the Rails trial, where patients with heart failure were improved. And so everyone was suddenly put on spironolactone. And then subsequently, there was this big rash of patients admitted to hospital with hyperkalemia. That was a big problem. And I think that when you look at using these agents, they have to be used very selectively. And the incidence of hyperkalemia in this trial, I don't know. So it may be that they prevented kidney disease, but it may be that that there were hospital admissions that were avoidable with hyperkalemia. So the answer is I don't know, and I certainly don't recommend that combination until I've seen more data from that, because it can be a big challenge, and many patients can do worse when you use that sort of combination, mostly from hyperkalemia, if they're not monitored correctly.
Thank you very much. I think that was a wonderful talk and excellent response to questions. If Dr. Jadhav doesn't have a question for Dr. Merlin, no,
I don't have. Thank you, Professor. I don't have a question.
And it's so late. Thank you very much for joining us. We learned, and you made a strong plea for the use of SGLT2 inhibitors. Hopefully that sort of bears out in our day-to-day clinical practice. Though you have shown the real-world data, we still possibly would need to see that, and would be happy to see that happening in the course of a treatment with patient. Thank you very much. Have a very good night.
Stay safe, everybody. Good night.
Yeah, you too. Thank you. So we would now come to the last but not the least important part of our program, another panel discussion. And we know we are getting late, and it's been a long period that we've been discussing. We'll try and do it as quickly as possible. So the theme for this is organ protection, which is the primary aim in diabetes management. And we have all our panelists with us. Of course, Dr. Uday Jadhav, the course co-director. Representing cardiology, we have Dr. Alok Jain, the nephrologist, Dr. Vipin Talwar, who has not formally been introduced. Can we go back? Yes, he's director and senior consultant in endocrinology and diabetes at Golden Hospital, Jalandhar, and he is vice chairman of RSSDI Punjab. We continue to have the help from Dr. Meenakshi Sundaram from Madurai, representing neurology. And we also now have ophthalmologists. We're very happy to have and welcome Professor Sandeep Saxena, who is Professor and Chief of Retina Service at KGMU in Lucknow. He's a visiting fellow. He has been a visiting fellow to various universities, Harvard, Oxford, Bonn. He has numerous publications. He has published 26 textbooks, and he has also designed a Saxena retinal grid. So we'll be very happy to have Professor Saxena amongst us. So if we can go down, and maybe we can start with any one of you, maybe Vipin, because we haven't heard from Vipin. One of the the Achilles heels of glucose management is the risk of hypoglycemia. We all know it has many adverse consequences immediately. And also we know the emotional strain of people going through hypoglycemia. They would like to be exposed to hypoglycemia again. And there are instances where people would rather have their glucoses be at 250 rather than have hypoglycemia. There is also suggestion that just like hyperglycemia, hypoglycemia also, episodes of low blood glucose also predict future development of cardiovascular events. So what do you think about it? Is it plausible, or is it just a chance association that one finds?
Definitely, Dr. Chaudhary, the hypoglycemia is one of very important consequence or a component of diabetes management. So this is one of the things which everybody is afraid of, the patient, the treating doctor, and even the family of the patient. And you know very well that as we try to go lower with HbA1c, the chance of hypoglycemia, they go up. And it has been clearly shown the data that if you try to achieve HbA1c of less than 6.5, your chance of getting hypoglycemia, they become 3 times. And as you have rightly pointed out, hypoglycemia is associated with short-term as well as the long-term complications. The one of the very important one, long-term complication is first of all the hypoglycemic unawareness. That is, the patient will lose the adrenergic symptoms, which are called warning signs of hypoglycemia, and he will directly land up with neuroglycopenia and diabetes coma or hypoglycemic coma. Secondly, there is increased chance of CVA and MI in the patients who get hypoglycemia. There is no doubt about it. Another important aspect of hypoglycemia in the long term is the neurocognitive dysfunction. And not to forget, repeated hypoglycemias, they cause damage to the retinal cells. We have got ophthalmologist in the panel. He can endorse this fact that repeated hypoglycemia is a reason for visual loss. More so, the patients with hypoglycemia, they've got very poor quality of life. They will have the poor sleep quality. They are not fit for many of the employments. Driving is difficult. They may not get driving lessons in many countries. In our countries, it may not be a problem, but it is a problem in some other countries. They find it difficult to go for the recreational activities. Their traveling may be difficult. And hypoglycemia increases the cost of treatment. Repeated visits to emergency center, it is associated with increase in the management of cost of diabetes. And in the last, I will just add, there has been one study which has shown that the people who get repeated severe hypoglycemia, they have got 6 times increased fold of chance of death as compared to those diabetics who do not get these repeated severe hypoglycemias.
Absolutely. I mean, therefore comes the role of glucose control without the risk of hypoglycemia. Hence, the increasing use of agents like the DPP-4 inhibitors or SGLT2 inhibitors on top of metformin, which do not give us the risk of hypoglycemia compared to sulfonylureas. Maybe another question is in relation to glucose monitoring. In order to pick up those hypoglycemias, especially at night and when you may wake up sweating and feeling unwell with tremor, it's sometimes difficult to distinguish whether the patient should go to Dr. Jadhav for a likely AMI or should be given with treated with glucose. And there is a scope, there is a possibility of using continuous glucose monitoring these days, rather than patients having to do their regular finger stick blood glucose test. So we cannot, of course, however, advise that to everyone. It's costly, first of all, and it's cumbersome as well. You have got something stuck into your tummy or into your arm all the while. So which would be the subgroups where you would advise continuous glucose control, monitoring?
Thank you, sir, for asking such a practical question, because the CGMS is a new weapon in armamentarium, which we are using for the management of diabetes in our day-to-day practice. Now, why the CGMS is important? As you have rightly pointed out, sir, the time is now coming when we are going to see the TIR, that is time in range for the diabetic person. That is the time for which he remains in the blood glucose level of 70 to 180. So this is called as a normal time in range for which the patient should have his blood glucose. And it is expected that patient should have at least 70% of the time of his day. That is at least 17 hours out of 24 hours, he should remain in this TIR. That is between 70 and 180. And it is said, if the TIR is lessened by 10%, there is increased risk of complications. Most of dreadful of them is again retinopathy. There is 60% increased chance of getting retinopathy if your TIR is reduced by 10%. A similar data is there for the neuropathy as well as the nephropathy. And interestingly, the carotid intimal thickness has been found to be higher in the patients who are not having this TIR in the normal range. So CGMS becomes very important. And exactly what should be the profile of patients to go for CGMS, it is not clear, but there has been a paper by Dr. Thomas Thomas Dane. It was in diabetology. He has clearly mentioned that CGMS is a preferred tool in all patients with type 1 diabetes and type 2 diabetes who are on intensive insulin therapy and are not able to attain or achieve their desired glucose control. Particularly, they are getting hypoglycemias. So if we translate into the practical matter, it means if your SMBG of your patient is not matching with the HbA1c, that is his blood glucose levels with his glucometer, whatever he's doing is normal, but HbA1c is haywire, and the patient comes, Doctor, I am getting hypoglycemias, but my HbA1c is still high. So he is the right candidate for going for the CGMS or the ambulatory glucose profile.
Also maybe the ones who have so-called brittle diabetes, having hypoglycemia unawareness, those may also be the ones who would benefit from CGM.
Exactly.
Thank you very much. Thank you very much, Dr. Vipin Talwar, for bringing those important points. So now we will move to Professor Sandeep Saxena. Again, the bias is to hearing from people whom we have not heard so far. People are eager to learn from you. So Professor Saxena, with your vast experience and knowledge, can you briefly tell us about the biomarkers for diabetes retinopathy?
Yes, diabetic retinopathy and the hemoglobin. So biomarkers from that aspect, lactated hemoglobin, homocysteine levels, and the surrogate biomarker in the form of serum creatinine levels are the ones we can measure in the lab. Now, over the past few years, I have also discovered vitamin D as a very important biomarker, which we can measure.
Maybe there are connectivity issues. I cannot hear Professor Saxena well. Can others hear well? Dr. Hiren?
No, there is a connectivity issue. There is a difficulty.
I think.
Right. So
can we take right? Can we meanwhile we take the discussion from the other members and just inform Dr. Saxena to connect again.
Okay, sir. Professor Saxena, we will come back to you. Maybe we go on to Dr. Uday Jadhav, our course co-director, and maybe ask about heart failure management in diabetes. Today, especially with the availability of these newer agents, the SGLT2 inhibitors, I think these agents are going out of the hands of diabetologists into cardiologists, and you also learned now going into nephrologists. So nonetheless, so heart failure management, first of all, would be the appreciation, the detection of heart failure and its management. So quickly, it's a vast subject, I know, but today we understand that heart failure contributes to very significant morbidity and mortality in people with diabetes. So how shall we go about it, Dr. Jadhav?
Yeah, so on a quick note, yeah, dapagliflozin data is very encouraging in non-diabetics, not just diabetics for heart failure. In fact, the relative risk reduction is a little better in non-diabetics than in diabetics. So we have a drug. Empagliflozin data on EMPEROR is positive. The final figures will be released at the ESC, but my expectation from having interacted with Milton Packer and Stefan Enker, the presenters, it's going to be positive. There are two more drugs which have come up. One is a drug called as vericiguat, but it's a little inferior to dapagliflozin. So that class of drugs is going to be not immediately used unless patient don't respond well. However, in the entire heart failure segment, the best drug that may come up, looking at the current data, is a cardiac actin-myosin activator, the actin activator, which is a inotrope or a mitotrope, as we call, which will improve the contractility of the heart. So the drug is called omecamtiv, and we have a couple of very big studies that have come positive with it, and we are looking forward to these studies, which will help the cardiac actin activator, the myosin activator, to improve the cardiac contractility. All parameters in the first 2 clinical trials have improved. So a new trial called Galactic Heart Failure is awaited, but it's going to be the way forward for this drug. And SGLT2 inhibitor, as I said, very, very positive in terms of this. Thank you. I'll make this comment brief. Thank you.
Yeah, thanks. I mean, heart failure used to be such a morbid event. I remember maybe when we were medical students, persons diagnosed with heart failure would hardly live for a year or so, 1.5, 2 years. So nowadays people are surviving so long. So survival has improved so tremendously thanks to modern treatment. So another quick one, of course, major cause for mortality in type 2 diabetes especially is cardiovascular, atherosclerotic cardiovascular event. So how would you prioritize in terms of reduction of ASCVD? So how important is blood pressure control in this? Especially, let's not talk about the stroke, for the heart protection, how important is blood pressure control?
So 2 very quick comments on this. One, which I already emphasized in my lecture, even in diabetics, non-diabetics, it's there. The CT coronary calcium score should be utilized because it's a class 1A indication given by the ESC now. And it's simple to do. It is the documentation of atherosclerotic presence, not just a risk factor, it's the presence. So one comment. Second is the blood pressure, particularly in the diabetics. Now that blood pressure will be monitored at home. So we have the home blood pressure monitoring in the COVID days. We have data from Japan, which probably is the best data on home blood pressure monitoring, which says if you get the blood pressure down to 120 systole in diabetics by home blood pressure parameter, not clinic, the event rate reduction is absolutely phenomenal. Even at 130 is there, but at 120 is so much better. So I think the good old average of 120 by 80 in terms of reduction of events, cardiovascular, and prevention of heart failure with a home blood pressure monitoring, whatever therapy we choose will be the way forward. Thank you.
Thank you very much. Can we, though we had a talk on kidney disease, can we go back to our nephrologist, Dr. Alok Jain? And we do know that today diabetic nephropathy is not just albuminuria. It could be albuminuria with or without reduced EGFR. So it could either also be just reduced EGFR. So what is the evidence base for prevention of progression of disease in those with diabetic kidney disease but not having significant albuminuria? How do we go about it? For example, the Credence study, they looked at people who had significant albuminuria and also had some reduction of EGFR.
Very good question, sir. Maximum has been covered by Dr. Merlin Thomas. But when you see this non-proteinuric diabetic kidney disease, what we say, this is an entity which has come up in early 2000, and a major chunk, around 14 to 18% of the patient who are having GFR less than 60 in type 2 diabetes were found to be having normal albuminuria. The reason for this was that they had a concomitant disease, like they can have a renovascular disease, they can have a senile atherosclerosis, they can have cholesterol emboli. And even those patients who are on RAS blockers, if they have been for a long time on RAS blockers, they can have further worsening of renal function. So these patients does not have that much amount of albuminuria, but they can have a derangement of renal function. And it is probably the macroangiopathy which is playing part in this rather than a microangiopathy. Usually diabetic nephropathy is a microangiopathic disease, but this non-proteinuric is a more of a macroangiopathic. As far as the treatment of this is concerned, because this has a very high incidence of having a cardiovascular event, according to the RIAS trials, where non-proteinuric diabetic nephropathy has more cardiovascular event being a macroangiopathic disease. As far as treatment is concerned, no specific treatment is there apart from the control of sugar, control of blood pressure, the control of lipids, which is there. There was some evidence that SGLT2 inhibitors might be helpful in prevention of progression of disease, but still we need more trials for this to have a good outcome, or to have a confidence in saying that in these group of patients, SGLT2 inhibitors may be helpful. in treating the patient. But what is important is to see whether these patients are on RAS blockers or not. And if they are volume depleted or they are on RAS blockers, then we have to deplete the volume, and then we have to stop the RAS blockers for some time to have an improvement in renal function. Otherwise, no specific treatment as far as non-proteinuric diabetic kidney disease is concerned.
Thank you very much.
Specific
The other issue is with the use of SGLT2 inhibitors with their very good organ protective effect. Now, they act primarily on the kidneys. And so it makes sense that if the kidney function has significantly declined, they may not be effective. However, this effectiveness is related more to its ability to reduce glucose levels. That effect may go down. However, the other organ protective effects may still persist and possibly persist. So what is the eGFR cutoff beyond which you feel SGLT2 inhibitors should not be used? Not that it's harmful, but it's not useful.
So we know that we have 3 SGLT2 inhibitors which we are using nowadays, that is epagliflozin, canagliflozin, and empagliflozin. So the studies says that empagliflozin is the drug which cannot be used beneath 45 ml of GFR. There are no studies which corroborate or they say that there is an improvement in the kidney function. Whereas canagliflozin, now there are trials which says that if it can be used till 30 ml of GFR, and if you are using it above 30 ml of GFR and the patient has further worsening of renal function, you can still continuously use it till the initiation of dialysis also. But important thing to remember is that the urine albumin excretion ratio should be more than 300 milligram. Then only it will have a beneficial effect as an antiproteinuric agent. And dapagliflozin, as we all know, can be used till 30 ml of GFR comfortably. Beyond that, it is still contraindicated.
Right. EMPA also possibly is generating data of its efficacy even up to 30. So, right. So now it's turned to go to...
One more thing I want to say. Sorry.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
So there is one more study which is now been recruiting worldwide, that is EMPA kidneys trial.
Yes.
Where they are recruiting around 5,000 patients, and they are recruiting till 20 ml GFR.
Yes. Yeah,
so
that's
something new which happening.
Sure. Thank you. So we now turn to Dr. Meenakshi Sundaram. So it's the neurologist's time now. So we talk a lot about diabetes and heart and myocardial infarction, but strokes also play an important part, and really the morbidity following a stroke, if the patient survives, is really probably much more than following a myocardial infarction. So what would be your maybe final take about stroke prevention in diabetes?
Thank you.
Quick one, please. Yes, sir.
Diabetes significantly increases the stroke risk as much as even 3 times. So keep your sugar under control all the time. And when a patient develops stroke, be sure to keep the sugars under good control, but do not overdo that at the time of stroke. I think these 2 statements will do for interest of time. So if I have to explain further, I would do that, sir, definitely.
So in terms of, let's say a diabetic had a cerebral hemorrhage at one point of time and then has recovered. So when can we start on an antiplatelet agent, which he needs otherwise, maybe for cardiovascular protection? He also had a MI maybe 2 years back.
The first thing is to assess whether this patient really requires an antiplatelet, which we have already said he requires. If that is the answer is yes, then you could, the rough ballpark time you could consider is 3 months. But sometimes if the indication is urgent, you could do it much earlier as well. The one important point we need to keep in mind is that when you have intracerebral hemorrhage, most of the times it is hypertension. So these patients should have perfect BP control. The BP should be less than 120/80 all the time. This has to be implied to the patient very clearly from the beginning. If that is there, then you could do it much earlier as well. Usually after the spontaneous ICH happens, after about 48 hours, there isn't much expansion of that. By around 2 weeks, when you look at that, the patients start having a decrease in the size of hematoma. In fact, even in acute hemorrhages, if you have to do a DVT prophylaxis, you don't have the luxury of having an IPCD or any of those things. You could start them on LMW heparin for DVT prophylaxis, even in the intracerebral hemorrhages I am talking about. Just putting it in the same perspective, the indication to use an antiplatelet is very high. You could do this much earlier, even as quickly as even 2 weeks. But if the indication is not absolutely indicated, we can still give a time for it to see. It's only a prophylaxis we have started. Then you may give it more time and give it more. For instance, a patient who had an MI only around 3 months ago, I would start within a week or 2 weeks itself. If a patient had an MI 2 years ago, I'd say cardiologist, I'd request them to wait for some more time. Still the hemorrhage actually resolves radiologically and clinically is doing better.
Right. The other part is to do with diabetes type 2, especially elderly population, who often have cognitive decline, maybe related to diabetes, maybe unrelated. And this in turn impacts significantly on his or her overall diabetes management as well. So can you sort of, for the basic clinician, tell us how quickly can we assess for dementia in such a patient, or cognitive decline in a patient in a busy outpatients?
So, how quickly we can assess, you are asking, sir?
Yeah. Yes.
Yeah.
For cognitive decline. Yeah.
If you want to pick up the cognitive decline, you can pick up with the usual scales which are available. So usually a mild cognitive decline would be missed. You could do some scales. For instance, a best clinical tool at the bedside to use is a Falstein's mini mental status examination. But these things would pick up the abnormalities much later. Now, when you have can I have a word about cognitive decline in particular to diabetes, sir?
Yes, sir. Yes, sir.
See, when you look at the levels of sugar and cognitive decline, you might be surprised to see that higher the sugar values, more will be the cognitive decline over a period of time. This is surprisingly true for even non-diabetics. In other words, some people come and tell us, I have no diabetes, I will thrive on sweets, which is not the correct thing to do. You give more sweets, you are going to accelerate the process of dementia in your, that's first important point. When you look at diabetics have more chance of developing dementia. Obviously, vascular dementia is quite understandable. Atherosclerosis, Uday sir were talking about, is very well known to us. That is going to accelerate the dementia. But what is interesting to know is that it is not just a vascular dementia. Even Alzheimer type of dementia sometimes is accelerated. One reason may be that the insulin degrading enzyme may have substrates which will sorry?
No, please, others, please mute. Yeah.
So ID has two substrates. One is your insulin, we will all know, and the other is amyloid beta protein. So surprisingly, even the Alzheimer's disease could actually go up. Patients have been shown to have some hippocampal atrophy in patients who have got diabetes. So it's far sensible to understand that keep your sugar well under control. HbA1c has got an inverse correlation with diabetes developing dementia, and that will be my take, sir.
Would you think about something quick as a clock face drawing test or something like that? That would quickly pick up.
In the extended MMSE, it's used, sir, actually. The Falstein's mini mental status examination, the original one, the 30-point score did not include that, but subsequently modification, but that's a very useful test, sir. Absolutely, you're saying, because it is going to check your parietal lobe, and dementia initially, as at least Alzheimer's, is going to start with the parietal. Absolutely correct, sir.
Thank you very much. So we will try and come back. So we go back to Dr. Saxena and hope that the connectivity issue is sorted. Professor Saxena, am I audible? Professor Saxena? Dr. Hiren?
Dr. Saxena, please unmute. Yeah, now it's audible. Yes.
I think the same problem is persisting. Yeah.
Okay, now hello. Yes, Lucknow has been cloudy today, so maybe things are bad. So
yes.
Now, okay. Yes. So I'll briefly emerging as a novel biomarker for the progression of diabetic retinopathy. So in case a patient has diabetic retinopathy, and if his vitamin D levels go below 18.6, then he is more liable to have a proliferative form of the disease. So that is one thing. Now this optical coherence tomography for the past 20 years has come up in a big way, and that has provided very nice imaging biomarkers for us. And here we have macular thickness. And the macular thickness correlates very well with the VEGF levels or the serum vascular endothelial growth factor levels. So now on a lab basis, it is difficult to do VEGF levels on a regular basis. But what our research showed a few years back, that VEGF levels and the macular thickness go hand in hand. So if a patient comes to us with retinopathy, we can monitor thickness. That gives us how good or bad his VEGF levels are, and then we can resort to anti-VEGF therapy. Some anti-VEGF therapies are the ones which are international and which are rather costly. And now we have biosimilar anti-VEGFs made in our country in the form of Razumab. So all these kind of therapies might help. So if we stay on these, and I feel serum creatinine level as a surrogate biomarker also goes very well, because there is a complex renal-retinal syndrome which goes on, meaning thereby that if the kidneys go down, the retina also go down. So serum creatinine levels also serve as a significant surrogate biomarker, and that tells that the things may go down the hill as the serum creatinine levels go up.
Right.
I hope I answered it. Yes.
Yes, sir. Thank you very much. I think it's been on for the last more than 3 hours.
Yes,
so
I think
we have So we have covered a whole lot of topic, and even without under the issue of organ protection and diabetes, I think we have had excellent inputs from all our faculty members. And we are really indebted to all of them for their inputs. I'd really like to thank Dr. Jain, Dr. Saxena, Dr. Meenakshi Sundaram, and we had earlier on Dr. Chakravarti, whom and of course we had Dr. Shah, who all gave us useful insights into overall management related to diabetes, different aspects, and of course, Dr. Jadhav very masterly conducted the session on COVID related issues, very practical and very up-to-date knowledge that was shared. So I'll hand it over to Dr. Uday Jadhav to provide the final comments and maybe on to the organizers.
Thank you very much, sir. Dr. Subhankar, it's been great. You started with a wonderful oration. It gives a different perspective in today's date, going beyond just the mundane aspects of medical science to see how we link the science and the art and the history and how evolution has taken us to this date. We had wonderful sessions. We had sessions to great panels. We have overshot the time because of so much discussion, to very good guest lectures on antiplatelet agents and also on diabetic kidney disease and multi-organ dysfunction. Thank you all the panelists, and on behalf of the Cross Connect, may I thank all who have joined us today and spared so much time to be here with us and bear with us for 1 extra hour and give us your time. Thank you very much, Hiren, for your final valedictory notes.
Yes, sir. Yes, sir. So we feel pride here to share with you that we have more than 6,000 registered delegates, and viewership just crossed more than 5,000. And I think that credit goes to all our course directors and all the faculties who has played a tremendous role here in today's evening, and so has a very wonderful scientific feast. I would also like to thank all the delegates who have joined us on this scientific platform called Cross Connect. So with this, I would like to thanks to all, and stay safe, stay healthy. Thank you. Thank you all.
Okay.